Hello, 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 my friends. It is Jill Osborne. It is time to do another live support group meeting. We have huge news today, like the biggest research news of 20 years. It's stunning. And it might help some people watching. Hello, YouTube. Nice to see you. Alrighty, so hold on a sec. I just got to get things kind of straightened out a little bit here. Hi, DJ. Nice to see you, hon. Hello, Facebook. Hello, you guys. Huge news today. Probably the biggest news in 25 years, maybe even 50 years. Brought to us by the top IC researcher, Dr. Robert Evans. Thank you, DJ. Thank you. Well, we are in a fire alert. That's why I'm late, because I am preparing for yet another one. Marian says, hello. Hi, Marian. Nice to see you. Ann says, can I get a CAT scan to see if I have IC? No, that won't help at all. And a diagnosis of IC is based primarily upon your symptoms. Do you have frequency, urgency, pressure, pain? Are you unable to sleep through the night? Do you not have UTI? Have they ruled out the other stuff? That is basically a diagnosis of IC. The only test which is particularly meaningful is having a hydrodistension with cystoscopy to see if you might have Hunner's lesions. But other than that, the only other test that might be used is urodynamics, and even that's not particularly meaningful, right? Hello, Pam. Nice to see you. All right, guys. Huge, giant, like biggest news ever. Hello, Corrine from Belgium. Hi, Ruth. Nice to see you guys. Let's just give it 1 or 2 more minutes. Let me pull this up. You are not going to believe it. So let me grab this email from our top IC doctor in the nation, top clinical doctor. Okay. Oh, this is so amazing. So amazing. Are you ready? Are you ready to be super excited? Like, seriously, like I'm ecstatic. All right. So a lot of you, so let's just get right into it, because we're going to share this. We're going to be talking about it all day, right? So a lot of you have asked, can I get a new bladder? Is it possible to get a new bladder? And the answer is, it's tricky. There's no such thing as taking a donated bladder and putting it in the bladder of somebody with IC. I'm not aware of any cases like that. But we have, especially 10, 15 years ago at Wake Forest University, they were capable of creating a bladder from your own tissue. So for people with a really severely damaged bladder, could they replace that bladder? And basically what they did was so interesting back then, is they would take a punch biopsy of your bladder wall all the way through. So we would have the mucosal layer, we would have the urothelium, and then they would have the smooth muscle, right? And then they broke that into 3 sections, and they grew out the muscle separately. They grew out the urothelial cells separately, and they grew out the upper cells separately. So we had 3 thriving populations of your cells that they could use to potentially create a bladder. Now, of course, these are cells. They're not in a structure. So what they did is they created a bladder-shaped structure of tissue normally found in a body, and they grew the cells over that. So on the outside of the cell, I think of it like a skeleton, for lack of a better term, or a scaffold. I think they called it a scaffold. On the outside of the scaffold, they put your smooth muscle, your bladder. And then on the inside of the scaffold, they did more the urothelial cells and the mucosal cells. So they were then able to make your own cells grow over a scaffold, exactly in the shape of a bladder. Of course, the problem was blood supply. How do we give that tissue blood supply? What they were able to do then is they were able to take some tissue along the inside of the human body that's very, 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 very rich in blood vessels and wrap it around the scaffold. And by golly, it started providing nutrition to this artificial bladder, right? And they implanted it primarily in children with spina bifida and other serious issues. And they were a tremendous success. They were great, worked well. So again, a lot of you have said, why can't I have my own bladder? Why can't they grow a new bladder for me? Because we know it's possible. Pretty expensive, but we know it's possible. Hence the email I got yesterday. One or two of you, maybe even more, might be able to get one if you've got a severely damaged bladder. So I want to read you the email that he sent to me. He says, we have been granted permission from the FDA to proceed ahead with the next phase of our bladder regeneration project, and we are looking for patients. Specifically, we need someone with a small bladder capacity, so it has to be under 150. So someone with a small bladder capacity with severe frequency who would be willing to participate in this bladder regeneration project. They would agree to undergo a procedure where we would first remove a 1 to 2 inch square piece of tissue, a piece of the bladder. This would then be processed and the cells placed on a scaffolding in a bioreactor, which is exactly what I said, and it would grow into about a 500 ml piece of new bladder tissue. We would then use this bioengineered augment to enlarge the bladder. The hope is that we would see a drop in the number of voids per day since the bladder would be so much bigger. This would not be for someone who has pain but does not have a small bladder. The ideal candidate would have what we in my lab refer to as a bladder-centric phenotype without other systemic manifestations. So in other words, when you're thinking about your subtyping, right, we're really thinking about IC subtype 1, IC subtype 2. They're not thinking about patients with pelvic floor or chronic overlapping pain conditions, which we know is a central nervous system issue, right? So the ideal candidate would have what we in my lab refer to as a bladder-centric phenotype without other systemic manifestations. Initially, I did not think IC patients would qualify for the study, but I've discussed this with everyone involved, and based on the criteria set by the FDA, there is no reason someone with IC cannot be considered for inclusion as long as they meet one of the other criteria. If someone is interested, they would have to be in our area or move here for the study. But if they do, we can help them find accommodation. If anyone on the IC network is interested, they can contact him or email him. Okay. Guys, do you realize how big this is? This is fantastic. This is absolutely fantastic that we are now at the stage where I see patients with a severely damaged bladder might be able to get part of that fixed. If you're, think about what happens with the bladder sometimes is that when the bladder is profoundly injured, or for example, if you've had Hunter's lesions and you've had them cauterized and you have a lot of scar tissue, so your bladder is kind of shrunken down to maybe the size of a walnut, right? Or a plum, for lack of a better term. And your bladder does not expand well because of the scar tissue to hold urine. So you've got a really small, you've got a really small bladder capacity. So what they are proposing to do is to take your own tissue, create a structure out of your tissue, which they can then use to expand your bladder capacity. What does that mean? Because it's your tissue, Very few side effects. They wouldn't have to worry about rejection. They also wouldn't have to worry about using bowel tissue to augment the bladder. The challenge is that when you use the bowel, bowel tissue is not meant for the bladder. Bowel tissue is meant for the bowel. And so for those people who have had augmentations in the past with bowel tissue, it's not ideal, because that bowel tissue is really not meant to hold urine. And so that tissue begins not deteriorate, maybe isn't the right word, but let's just say it can become quite irritated. So they are now able to do it with your own tissue. Do you realize how huge this is? This is stunning. Absolutely stunning. What we have waited for 25 years. So again, for those of you who have said, can I just get a new bladder? The answer is maybe with your own tissue. Maybe with your own tissue. Now, Wake Forest University is obviously the home of Dr. Robert Evans, who is voted Doctor of the Year every year that we've ever had a Doctor of the Year. Patients love him. He is a very sweet, kind personality. Been massively involved in ICU research for 30, 40 years. Heavily involved with the National Institutes of Health. He knows his stuff. He absolutely knows his stuff. But what a lot of you don't know is that Dr. Evans is a meticulous surgeon, and he has been doing these surgical implants. So it's stunning. It's exciting. So for any of you out there who have a very, very small bladder and you're over it, I need you to email me. You need to email me. I'm not going to give his email address out on the internet because he wants to hear from you directly. But I'm not going to share his email address online. I mean, in this forum. If you think you meet that criteria and you are sincerely interested in participating in this groundbreaking, revolutionary research study, I need you to email me, icnetwork@mac.com. icnetwork@mac.com. M as in Mary, A as in Apple, C as in Charlie. And I will send you his information, or I will send your information to him. Okay? So, what do you guys think of that? Isn't that amazing? Hello, Marjan from Sydney, Australia. So nice to see you. Hello, Liz from Ontario, Canada. Hello, Debbie from Long Island, New York, home of Dr. Robert Moldwin, who you say is your urologist and it's helped you so much. Anne says, so CAT scan can show tumors. Well, IC patients do not normally have tumors in our bladders. I mean, if you're peeing blood, that's a sign of bladder cancer. Like if there's significant blood in your urine, normally what they would do first is they would do something called a urine cytology. It's a urine test. You pee in a cup, they send it off to a lab, and they look for cancer markers. If that comes back positive, then they might want to do a cystoscopy or hydrodistension with cystoscopy and look inside your bladder first. And then if they think that they've seen something, that's when they might do more imaging to try to understand the scope of what they're seeing, right? Anne says, does estrogen cream help with urgency frequency with either with IC or OAB? Estrogen cream does not act on nerves. It does not act on the alpha afferent nerves, which are driving your frequency urgency. What estrogen cream will do is it will help your skin produce more mucus, which will then protect those nerves. And so the question is will that potentially help what we call the genitourinary syndrome of menopause, where your skin is very dry, your bladder is very dry, thus you've got frequency urgency because the nerves are kind of exposed? The answer is estrogen cream could be remarkably helpful. Anne says, do urologists do narrowband imaging? Only a few. It's an expensive piece of equipment, and a lot of labs don't, a lot of doctors cannot afford to put it in their clinic. Corrine said, my doctor recommended neobladder operation. So Corrine, kind of the same thing. Kind of the same thing. Uh, so with a you're going to have to find out specifically what they would intend to do. Are they intending to remove your bladder completely and either attach your ureters to a stoma or build you a new bladder out of intestinal tissue? But again, think about how critically important this new opportunity is. To be able to grow a bladder with your own tissue is insane. It's fabulous. There would be no rejection. You wouldn't have to be on immunosuppressant drugs, right? So the long-term outcome of using your own tissue is much better than the long-term outcome of using foreign tissue. Hi, Boria. Boria says, how am I? I'm excited, but I'm also a little freaked because we are entering another very, very severe fire thing tonight at 11. And I even canceled my oral surgery tomorrow. I'm supposed to have oral surgery, but I have to be here to move my parents. So if we have a fire, lots of deep breathing, lots of deep breathing. Bethany said, I've been reading today about the BRRS score bladder permeability defect score. A urine test can detect tendernous lesions without doing the hydrodistension. Have you heard of that? I think that, Bethany, I have heard of that. I haven't really read up on that. That's pretty new. And I don't really know anybody who's doing it. Brandy said, so in order to qualify, we need to have a doctor document the size of the bladder. They would want it under 150, not under 100, under 150. So Brandy, if you're interested, email me, icnetwork@mac.com, and I will send you his letter so that you can talk to him personally. Because whoever does this is going to be a hero in the IC world, an absolute hero in the IC world. Chris says, oh, Brandy, where's the area? North Carolina. Rhonda, what you missed is we now have an opportunity to participate in a brand new research study at Wake Forest where they are now growing new bladders from your own tissue. And so Robert Evans, the principal investigator in the study and the top IC clinician in the United States, sent me an email yesterday saying they are looking for a patient to participate. They really want a patient to participate in this. But you have to have a small bladder capacity and you can't have other systemic issues going on. Inga's talking about goodbye UTIs, Duke scientists. I think you're talking about the UTI vaccine. Yes, very, very exciting with the UTI vaccine. Not going to help IC, but it's going to help millions of women and men who struggle with recurring infections. Manda says, in my opinion, having IC, pyelonephritis, CKD, modular sponge kidneys, family history of kidney stones, as well as this started for me at 15. I have an extensive history of the issue as well as surgeries to prove. Honey, it is accepted as a disability if you document it correctly. You know, given everything you're saying to me here, as well as the fact that that you've had long-term sepsis, that you have a chronic and ongoing condition, multiple kidney conditions, as well as IC, as well as endometriosis. If your disability application is written correctly and the evidence is good, there's a very, very good chance you could get disability insurance. You have to remember there are four types of disability insurance. There's private insurance from your employer. There is state disability insurance. State disability insurance normally it lasts a year. The intention of the state disability insurance is to get you back to work. You pay for that out of your paycheck. If it's a longer term disability or the doctor doesn't think you're going to be able to return to work, then you're going to do Social Security disability, but you must have worked and paid into the system roughly 10 years or earned 40 quarters of credit to qualify for Social Security disability benefits, and Social Security retirement benefits. If you're under the age of 30, there is a test, and it's impossible for you to have worked 10 years. There is a specific wage test that they can use that where you might qualify too. Um, so again, Social Security disability is about having a doctor say that he does not believe you will be able to work again. Then we have supplemental security income. Supplemental security income, SSI, are for patients really who have not worked, patients who are profoundly disabled. It was originally created for people who were blind and had other profound disabilities. So SSDI, supplemental security income, and it's a very minimal payouts. And you have to be really disabled to be qualified for that. Social Security disability, you have to build your case. And you have to be prepared for the fact that they deny 80 to 90% of applications first round. I worked there for a year before I went back to grad school. I was a black lung specialist for Social Security for a year. And I will tell you that in my opinion, the denials are just to kind of test your reserve because they hope you'll walk away. And we always say, don't walk away. For God's sake, if you get a denial, immediately request a reconsideration. Most patients are approved at the first or the second appeals, right? Once you get in front of an administrative law judge, you should be good. But it's all about the information you give to them. You have to give them good information. I have a whole disability resource center right on the IC Network website. Just go to icnetwork.org, go under self-help, and you can go in there. I got a lot of information in there to help patients who are trying to apply for disability. Kayleen says, happy Sunday. I think my strep is gone. Oh, you guys have a hallelujah for Kayleen, who has struggled terribly for the last couple of weeks with a terrible infection. Kayleen, I'm so happy for you, hon. Keep it up. Hello, Marie from Georgia. Sarah says this is good news. Hi, Marcia. Thank you for the 99 stars. Megan says amazing news. Leslie says, when will they approve Humira for IC? I don't believe that it's in the research chain for FDA approval for IC. Let me check. Hold on a sec. Let's see if they're even doing the last round of studies. So let's see. I didn't think really anything was in the queue for IC. So let's see. I'm at clinicaltrials.gov and I see studies for arthritis. Study for COVID was withdrawn. Plaque psoriasis. I don't think it's in the queue. I might be wrong, but I don't think it is. Manda said, I'm discriminated against for having this. It's ridiculous. Girl, we've all been there. I lost a job because of my IC. They just terminated everybody on disability. I still didn't even know I had IC. I thought I had cancer. I was waiting for cancer surgery. And they still fired me. The only time I've been fired, and it was very traumatic. Brandy said, I have traces of blood in my bladder. Every time I do a UA, I have cystoscopes every 2 years to rule out cancer. Is it common to have blood in your urine? Yes. It's very common to have a microscopic blood in your urine. Because if your bladder wall is irritated, let's just say you were exposed to ketamine, which we know is tremendously irritating, right? So what happens is the chemical kind of eats into the bladder wall and you end up with the equivalent of a chemical burn. The human body reacts to that by sending white blood cells to the area through the blood vessels to go defeat and fight defeat the offender. But the really fascinating thing is, how do the white blood cells, the lymphocytes, actually get into the tissue? And the answer is that the little tiny capillaries release them. And when they release the white blood cells, they release red blood cells too. And that's why many of us who have just minor bladder wall irritation might have microscopic blood in your urine. They're really not worried about microscopic blood in your urine. What they're worried about is visible blood. If you're peeing blood clots, if you have a pink toilet after you pee, or you see, or dark red, or if you're passing blood clots, that is a totally different story. And that is where you must immediately call your doctor and let them know you are bleeding, because they need to figure out why you're bleeding. Is it your kidneys are bleeding? Your bladder wall might be bleeding because of cancer or because of a UTI, something like that. But the microscopic blood, I've had microscopic blood in my urine every single time they've ever tested it, like my entire life. Chimera says those Social Security disability papers offered are worth thousands of dollars, especially if used before your first denial. I would not have needed a lawyer if I had them. Yeah. Yeah. I mean, we really provide a lot of good information about it. And the ICA has a disability pack you can buy from them. It takes a while to get it, but even that might be useful too. Anne says, how do you get a correct diagnosis of IC or OAB? The big difference between the two, since they both cause frequency urgency, it is urgency. If you're running to the restroom to reduce pain and discomfort, that's IC. If you're running to the restroom because you're afraid you're going to leak and you're trying to prevent incontinence, that's overactive bladder. Julie says, I have a neurostimulator put in my back. Could it also help my IC? Potential. Well, it depends upon where the leads are, hun. You have to put the leads on the nerves which support the pelvis and support the bladder. Susan said, I've had lots of blood and blood clots and have tested 3 times for cancer. I have scar tissue over from being cauterized. I'm now on an antibiotic and estrogen ring. Haven't bled, but have significant pain. Do you think I would qualify for the study? Susan, I don't know, but if you email me, icnetwork@mac.com, I will email you his contact information and you can reach out to him and ask him that question. Guys, like seriously, the top IC clinician in the country, this is a great opportunity. Kaylee, let's see. Thank you, Lisa. Thank you for the 500 stars. Kayleen said, I do feel like the last installation helped, but I did find a fingernail sized blood clot this morning. Yeah, but hon, you did have an instill. Pamela says, my husband has black lung, no money for it. Yes, I know. Debbie, hello from Wisconsin. Nice to see you, Debbie. Anne says, is overactive bladder the same as IC? Similar, but again, if you're running to the restroom for pain, to reduce pain, that's IC. If you're running to the restroom because you feel like you're going to leak, that's overactive bladder. Deborah says, I never had to watch my diet with IC. This summer I had a hydro that caused terrible pain for 2 months. Now almost everything bothers me. Working on building a diet. I used to shake and bake. I used some shake and bake chicken last night, had pain. Let's see. Didn't know it would hurt, had pain today. If we eat something we shouldn't, how many days does it take for it to clear out? It really kind of depends upon the damage done. So, if, for example, you had tomato soup, like really strong tomato soup or chili, then that's probably going to cause a lot more irritation in those tissues because of the acid of the tomato than maybe the spices in the shake and bake. I used to love shake and bake chicken. I haven't looked at the ingredients recently. I don't think I've used it in 20 years. Let me see if I can find the ingredients and let's just take. Let's look at the ingredients real quickly. It's made by Kraft. Here it is. So it's got wheat flour, vitamin B1, vitamin B2, enriched bleach wheat flour, maltodextrin, salt, canola oil, paprika. contains less than 2% of high fructose corn syrup, celery seed, spice, yeast, dried garlic, dried onions, natural flavorings. So we don't know what that spice is. You might be sensitive to the garlic and the onion, hon. You might be sensitive to the garlic and the onion. I don't think I really introduced myself. For those of you who are new, my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the National IC Support Group leader, the longest serving support group leader in the country at 28 years. In fact, I was thinking about the exact month. Okay, well, we're past that. It'll be 29 years next September. Um, I am a writer. I've written a lot of materials on IC. Our website's rated #1 in the world by Harvard Medical School and the University of London in 2 peer-reviewed studies. I'm a co-author of the brand new book IC 101. And so I would be more than happy to take your questions. Understand that I walk a fine line between, I balance 3 things. Number 1 is I love the research because I have a research degree in drug development pharmacology. I love doing research. I love participating in research. Our study, we've done many, many studies for the IC network that have been published in major medical journals, et cetera, et cetera. We did the really pivotal study on pigmentary maculopathy and IC for patients who are having eye issues. So I love doing the research, love writing, love working with patients. But I also own a business, and that is the IC Network. We are a health education company. But I'm a support group leader first. I'm a business owner last. Because I'm a patient just like you. But I do have things that we sell, like our book, et cetera, et cetera. So I think for those of you who watch, you know that I'm very, very balanced there. All righty, let's see here. So Deborah, getting back to you, it might have been a reaction to the onion or the garlic, although maybe you might be sensitive there, but I would expect that this flare would resolve very quickly based upon what I'm seeing with the ingredients. Anne says, I have no pain and I don't leak. So what is it? Well, if you don't have pain as your bladder fills, then it's either a very, very mild IC or overactive bladder, Are you food sensitive? Hi, Jeannie. Tashona says leads for what? Okay, so for those of you who come in late, we made a really, truly stunning announcement, and that is that they are now looking for IC patients who would be interested in having a bladder regeneration using their own tissues. So this is something we've been waiting for 30 years. The question is always, can I get a new bladder? And the answer has been kind of no. No, we really haven't had new bladders. But about 10, 15 years ago, Wake Forest University was the first to create an artificial bladder made from your own cells. And they were quite successful with that. And those were implanted in usually children with spina bifida or some sort of other serious disability in a young child that would affect their bladder. This is the first time now they are looking to do it on adults. So if you have a small bladder capacity and your bladder capacity is under 150 mLs, I need you to eat, and you're interested, you might have to relocate to North Carolina. They will help you with that. What they're going to do is take a 1 to 2 inch piece of your tissue, and then they're going to grow it out. They're going to grow it out. Each different part of the bladder gets grown out separately. Then they implant it on a scaffold. So now it has a structure that is similar to what the bladder looks like. the advantage of this is we aren't risking rejection. Normally when you have transplanted organs, you have to be on immunosuppressant drugs because the risk of rejection is so high. Well, but not if it's your own tissue. And so this is something we have been waiting for decades. And he just emailed me yesterday. They are looking for a patient who would like to participate with a small bladder capacity, who is anyway, I can read. Let me just read this again. We have been granted permission from the FDA to proceed ahead with the next phase of our bladder regeneration project and are looking for patients. Specifically, we need someone with a small bladder capacity of under 150 ml with severe frequency who would be willing to participate in a bladder regeneration project. They would have to undergo a procedure where we would first remove a 1 to 2 inch square of bladder. This would then be processed and the cells placed on a scaffolding in a bioreactor, and it would grow into a 500 ml or so piece of new bladder tissue. We would then use this bioengineered augment to enlarge the bladder. The hope is that we would see a drop in the number of voids per day since the bladder would be so much bigger. This would not be for someone who has pain but does have a small bladder. The ideal candidate would have what we in my lab refer to as a bladder-centric phenotype without other systemic manifestations. Initially, I did not think that IC patients would qualify for the study, but I have discussed this with everyone involved, and based on the criteria set by the FDA, there is no reason someone with IC cannot be considered for inclusion as long as they meet the other criteria. If someone is interested, they would have to be in our area, which is North Carolina, or move here for the study, but we would help them find accommodations. If anyone in the IC network is interested, he is asking you to contact him. But I'm not going to give his phone number over the internet, okay, over this live stream. You have to email me, icnetwork@mac.com, if you are interested in learning more about this study, and I will send you his email and you will be able to contact him there, okay? So this is huge. This is huge. Hi, Kathy says, hello from Texas. Really appreciate everything I learned. Thank you, honey. I wish I had more time to read. You know what? Oh God, I had a hysterical nightmare before I woke up. I dreamed that I was in a PhD program about IC, and that my committee asked to meet with me as I went through all of my theories on why IC happened, and they wanted to have all the research, and they gave me an hour's notice. And the chairman of the committee was Dr. James Malone Lee. That was my nightmare. I mean, because obviously he doesn't really believe in IC, so of course he's going to shoot down my theories about what causes IC. Anyway, that was I had right before I woke up this morning. It was a great dream. I was like ready for it, man, but just like, give me a day, not an hour. Give me a day so I can write it down for you. Of course, it's all written right here in IC 101. You guys, this is our new book on IC. This is the first book that goes over subtypes, the diversity in the IC patient population. Because listen, for many of you, bladder therapies will not work. They just won't work. The reason why is because something outside of your bladder is involved, usually tight pelvic floor muscles or your central nervous system or ischemia. There are other issues that can trigger all these symptoms. Rebecca says, I had my breast implants removed 2 weeks ago to try and bring my inflammation down. Good. They put you on antibiotics. When you got off of them, you got a UTI. Is that common? I'm hoping my IC isn't bad. Well, honey, anytime you're going to be in the hospital, you're running the risk of something called a nosocomial infection. That is a hospital or medical care facility acquired infection. And so it doesn't surprise me that happened. But I'm not saying I understand why it happened. I mean, technically, removing your breast implants shouldn't affect your bladder, but you are going to be exposed potentially to bacteria in the operating room that could have gone into your body that could potentially have created some sort of systemic infection, maybe. You should make sure you tell your surgeon that removed your breast implants that you've got a UTI. They really need to monitor that. But you got to be very careful with that. Hi, John. Nice to see you. Hi, Mary. Marion says, I'm on my 7th antibiotic in the past 7 months. That's not good. Why? Jody says, I'm going for a hydrodistension at the end of the month because either the meds I've been prescribed haven't worked or because my insurance won't pay for it. I'm hoping it helps. So, all right. So, Jody, listen, you have to understand that not every IC patient is the same. The other thing you've got to understand is we don't even think of IC as an incurable bladder disease anymore. We think of it as a pelvic pain syndrome. Why? Because structures outside of the bladder are often involved, if not causing the problem, right? And so today, we have a couple of different types of rules. Rule number one is if a patient isn't responding to therapy, the American Urology Association says, stop what you're doing, take a step back, and revisit the diagnosis. Did we miss something? Is there something else that could be triggering your symptoms, such as a fibroid tumor pushing on your bladder, such as endometriosis on your bladder, a Tarlov cyst, or far more commonly, extremely tight pelvic floor muscles, or some sort of physical injury, bony structure abnormality, which is tweaking those muscles and giving you something called ischemia. So the hydrodistension is, you know, I don't like guessing. I like facts. And if you suffered over a period of time and you're not getting better, there absolutely comes a point in time when you have to let somebody look. And I think it's good that you're letting somebody look at your bladder. Um, you need to make sure that they're doing what we call a low pressure, short duration procedure. In the old days, they used to do high pressure, long duration, where they would put a lot of fluid in the bladder and kind of stretch the bladder. But sometimes bladders ruptured. And so in the new AUA guidelines that were released in 2011, that's 10 years ago, they're basically telling all urologists, stop it. Don't do that anymore. We're doing a low pressure, short duration hydrodistension because we want to look at the bladder gently. We don't want to traumatize the bladder. So here's the deal. If they look in your bladder and they don't see anything, that's great news. That means then that something outside of your bladder is the problem. And that's where you've got to be a bit of a detective. You are an anatomical mystery to be solved here. And I would hope that you have at least had a pelvic floor assessment so that they've looked at your muscles. But it's time to start looking at other things too. Okay? Don't sit in the bladder bandwagon. We've had patients who've done bladder therapies for 10, 20 years. They never got better. And the reason why is because it wasn't their bladder in the first place. Just remember, the bladder can be injured, can be the victim of another dysfunction in the body. And that ultimately is the challenge facing you as a patient and your doctors, is we have to figure out what that could be. And there are many, many different things that can cause these symptoms. As an example, I'll give you an example, give you a really interesting example. So your urethra, which is the little tube that goes from your bladder out to your skin, right? And it's what you pee out of. Your urethra is roughly the size of your little finger, okay? I mean, it's short, like 2.5 inches, maybe a wee bit longer, but not much longer, right? So I worked with one patient who was diagnosed with IC, but her symptoms were really all urethral. And honestly, the urethra, the only time we really see a lot of urethral involvement is with estrogen atrophy or UTI. For her, it was just urethra, 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 urethra. She'd done all the bladder therapies. It didn't work for her. She went to many, many doctors. Didn't work. And finally, one nurse practitioner listened to her. And the nurse practitioner said, you know what? We need to take a look at your urethra. And they did either a CAT scan or an MRI, I'm not sure which. And she had a fistula. So here was her urethra. There was a little tiny tube, and next to her urethra was a long tube connected to it. It was a fistula. Now, fistulas sometimes happen because of straining. Think of it, as a cystocele or rectocele. It's kind of a uretocele. I don't think that's a real word, but it was basically a fistula. It was a structure that left the urethra, right? So she had two tubes, only one of which was connected to her bladder. The other one was filled with urine and not draining. And it was a massive source of infection, a massive source of discomfort. They went in, surgically removed the second one, cured. Cured. But it took her years to get somebody to listen to her. And that's the thing, is your ability to discuss your symptoms with your doctor is essential. You can't walk in and say, I have IC. You will fall down the rabbit hole. Do not do that. You have to walk in and say, doctor, I have pain in my urethra that hurts whenever I pee. Or doctor, I have pain on my left side. Or doctor, I have pain on my perineum. Or I get this really weird pain when I sit down, but it improves when I stand up. Or occasionally I'll get a shooting pain down my leg. Or sometimes my tailbone will throb. Um, you know, the devil is in the details here. Your ability to discuss the minutia of your symptoms. Often it's that little random symptom that only happens once every 2 weeks that confirms the diagnosis, right? And so you need to be able to walk in and say, here are my symptoms. Can you help me understand what could be triggering these symptoms? Without even saying I see. It's just important. Unfortunately, I see, even though it was discovered in the 1800s, in the 50s, two arrogant pricks of doctors published a case study of a woman who they claimed had unexpressed anger manifested in the pelvis, and that it wasn't a real bladder condition, that this person needed psychotherapy. And they published this paper. And from that moment, all the way up until probably 1990, many medical schools taught that IC was mental and emotional. I will tell you now that the National Institutes of Health have invested well over $100 million into IC research. We know for sure IC is real. It is not mental and emotional at all. This is a real condition, but there are variants in these conditions. Some of you might have Hunner's lesions, which is its own unique disease. Others of you might have pudendal neuralgia because you got pain that sits down that goes away when you stand up. And a huge number of you, like me, have IC, IBS, vulvodynia. You've got a lot of other pain conditions, and that's up here in our central nervous system. And if people want to know about that, we'll talk about that, because now we know why bladder therapies failed those people, because they're not targeting the nerves. This is about targeting nerves and getting normal nerve function restored, for lack of a better term. So Shauna says, I don't get the UTI. I just have blood and pain. But I also have SCS, which has helped me a lot. I don't know what SCS is, honey. Can you tell me that? And I know that I'm now 15 minutes behind in questions on Facebook. Let me check YouTube here real quick. Eileen says, you need better dreams. It was a challenging dream. Like, I was ready for the challenge. Eileen says, I'm 61, and at 32, when I was diagnosed, I was told by a urologist to get married and have babies. Yeah, that's actually common. I think Vicki Ratner, who is the founder of the ICA New York group, I believe when she was in medical school and developed IC, that somebody told her the same thing. That's one of the reasons why she got involved in the IC movement. Lauren says, I'm going to a new urogynecologist in a month for my IC. I don't want a cystoscopy. Do I need to agree to one? Well, honey, you listen. If you don't let them look in your bladder, you're forcing them to guess. And guessing will only get you so far, hun. Guessing will only get you so far. I mean, if you have pain, don't you want somebody to look to see if they can figure out what the pain's coming from? Because if you got pain, that could be Hunner's lesions, which are completely treatable. So, and I've shared this story many times. We had a patient who did not want a cystoscopy. She refused it for years. And finally, her condition got so bad, she agreed to it. And when they looked in her bladder, they found a bladder stone. This giant, giant stone floating in her bladder, cutting her bladder. And when they broke up the stone, guess what happened? Her symptoms went away. Now, she suffered, unnecessarily for years because she wouldn't let somebody look in the bladder when she had a very, very easily treatable condition. So at some point in time, I mean, I've had I've had maybe, let's see, I've had 2 cystoscopies by the urologist, but 1 hydrodistension by my gynecologist. I mean, my personal approach is if I'm in pain, I want somebody to look at it and tell me why I'm in pain. I don't want anybody guessing. If it's lasted 6 months or I'm bleeding, I want somebody to look. That's just me. All right. Lisa says, what subtypes might benefit from the new procedure? I think I see subtype 1, subtype 2. I think subtype 1, Hunner's lesions, if you've had a lot of lesions that were treated and your bladder's now scarred and shrunken, that might qualify, as well as maybe chemotherapy, chemo-induced cystitis, where the bladder has just shrunken and reduced capacity. Hello, Marion in Ireland. So nice to see you. Lauren says, would food bother your bladder if you have tight pelvic floor muscles? Yes, it would if you've had tight pelvic floor muscles for a long period of time. Understand, I call this the chicken versus the egg dilemma, my friends. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor. They're both involved, but one is normally driving the other. And so we have got to try to figure out which is primary, which is secondary. So for some of you, I see your symptoms might have started because you were just drinking way too much diet soda, or you went through chemotherapy for cancer. So your bladder is being really badly irritated by chemicals. And because you're in pain, your muscles will get tight to protect you from that pain. But our therapeutic priority for that patient is to stop irritating the bladder. If we can calm the bladder down, the muscles should release, right? The guarding reflex, you have no control over that. When you're in pain, your brain tells your muscles to get tight in that area to protect you from that pain. So concept number 1 is bladder injury causing your muscles to tighten. But the much bigger group is the patients with a muscle injury. So in that case, you at some point in time, your pelvic floor was traumatized. Let's say you fell down, or you were a gymnast or a dancer or a paratrooper or a professional football player, whatever. At some point in time, your pelvic floor muscles started taking some blows and it becomes injured. If you fell on ice, if you fell on your tailbone, that's classic. So your muscles, every time they're traumatized, they are injured. And over time, what does that cause? That causes muscle weakness. And a muscle that's weak still has a job to do. So what happens is it becomes tighter to do that job. It has to hold on tighter to keep that joint together, like your SI joint. So one day, out of the blue, you get urinary symptoms, frequency, urgency, pressure, pain. You're going UTI. Call the doctor. Hey, doc, I think I have a UTI. Doctor goes, okay, throws you some antibiotics. They don't work. You go back to the doctor. The doctor goes, well, let's culture out your urine. They culture out your urine. It comes back clear. You're still having symptoms. You go back to and of course, your doctor might have said, well, let's just do some long-term antibiotics. So you might have been on antibiotics for 3 months, 6 months, a year, whatever. But in the end, it hasn't worked. You go back to the doctor. The doctor goes, oh, I think you have overactive bladder or prostatitis. And they either give you the overactive bladder meds or the prostate meds. And you do those, but they don't work. 6 months later, a year later, 2 years, 5 years later, you're still suffering. You go back to the doctor, and the doctor gives you the dreaded, I think you've got interstitial cystitis, this incurable bladder disease. I'm so sorry. Here's the diet. Here's Elmeron. I'll see you in 6 months. And you're like going, what the hell? What the hell's interstitial cystitis? You have no freaking clue what interstitial cystitis is. But you want to get better. So you're a good girl. You follow the diet. You take the Elmeron. And over time, 6 months, a year, 2 years, 5 years, 10 years later, you're flaring all the time. You're really not better. Why? For this patient, bladder therapies will never fix it because the underlying problem in the muscle injury patient is poor blood supply, ischemia. Muscles are so tight, they're restricting blood flow to the bladder. It's very hard for the bladder to be healthy if it doesn't have good nutrition and good oxygenation. It's called ischemia. And so over time, that takes a toll on the bladder, and the bladder wall will become injured, and you will become food sensitive. But in the end, until we restore blood supply, until those muscles get released, that patient is probably going to suffer for a period of time. And when you look at the statistics for Elmeron, you look at the data for Elmeron, it's in the great majority of studies, it's no better than placebo, maybe slightly better than placebo. Why? Why don't bladder therapies work for a lot of you? Bladder therapies never worked for me. They didn't work for me. Why? Because it's not my bladder. It's my freaking pelvic floor muscles. And I go back to 7th grade when this all began for me. I had broken my tailbone. Like, I originally thought that I was just a victim of a random series of events. But in the end, we understand fundamentally that pelvic pain is very complex, and that Western medicine fails the pelvic pain patient because doctors like to play in their sandbox. Urologists like to stay in the urinary tract. Gynecologists like to stay in the reproductive tract. Gastroenterologists like to stay in the bowel. And the problem with the pelvis is it's a small confined area with a lot of structures, and nothing operates in isolation. Everything influences each other. So you got muscles that influence organ behavior. You've got organs that influence nerve behavior. You've got nerves that influence organ behavior, et cetera, et cetera. Nothing operates in isolation in the pelvis. There are a lot of influences, like a fibroid tumor pushing on your bladder, causing symptoms, right? So again, you are an anatomical mystery to be solved. We no longer think of everybody having an incurable bladder disease. Couldn't be farther from the truth. Alan says, I did extreme exercises and got injured. After a while, I was diagnosed with IC. Exactly. And I've had long-term levator ani issues that were exacerbated by surgery. And then a month ago, I did a new workout routine, and holy hell, did the gates of Armageddon open up in my pelvic floor. And it's taken a month for things to calm down. These pelvic floor muscles are really traumatic. And the irony, my friends, is if you go back 100 years and you look at the papers urologists are writing about IC, they were describing muscles so tight they resembled tight piano strings. They were seeing it, but they play in their sandbox. They were only treating the urinary tract. They were not treating muscles. And we have to treat the muscles too. Anne says, here, hold on a sec. Lauren says, what food would bother your bladder if you have type? Well, any irritating foods, coffee, soda, vitamin C, ascorbic acid, citric acid, things like that. Same things. Sarah says, I do not have a small bladder, but I do have other IC issues. Okay. My bladder is like, I think when they measured it last time, it was like 350, somewhere in there. I mean, it was a long time ago. Anne said, what liver, thyroid, hormone supplements can I take? Everything I try gives me a flare. My doctor says I need to take these supplements to help help other issues out. I wasted so much money. Well, honey, I'm not an expert on liver supplements or thyroid supplements or even hormone supplements. The challenge with a lot of the stuff on the market today is that a lot of it uses ingredients from China, and we just don't know, the quality of those. I'm very suspicious of some of the soy estrogen stuff that comes from China. I personally would not take it. Um, I just don't know. I mean, if you I would look you're gonna need to look at the ingredients and look for irritants in the ingredients. Like, if there's ascorbic acid or citric acid in it, then you're probably not gonna be able to do it. Hello, Jennifer from Wisconsin. Hello, Gay from Texas. DJ. Holy crap, DJ. I'm back in the hospital with Klebsiella with ESBL, but also because of my gastroparesis. They had to place a gastro tube. Feeling exhausted, but sending you all good oh, honey. Big hug to you, my friend. Big giant hug to you, and thank you for the 100 stars. I hope that they can get that Klebsiella under control. Crap. The gastroparesis is tricky, all I can say is that having some, I also have mild gastroparesis. The foods which set off my gastroparesis. So gastroparesis, for anybody watching this, is delayed stomach emptying. It means that food sits in your stomach for a much longer period of time than normal, and it starts to ferment. So the number one symptom of gastroparesis, aside from being full, is belching. You having painful belching. And for me, the foods which always trigger that are leafy greens. Leafy greens are fine for my bladder, but for my stomach, it does not work. Leafy greens are very hard to digest. Normally, when you have gastroparesis, you have to eat foods that are easy to digest. And so once I stopped all the leafy greens. I don't eat lettuce. I don't eat kale. I don't eat spinach. Even chopped up doesn't work. It still ferments. I eat a ton of salad. I just don't eat lettuce with the salad. I eat cucumbers and carrots and beets and mushrooms and all sorts of stuff. I just don't eat leafy greens. And my stomach and my gastroparesis is much better for it. Brandy says, what's the treatment for Hunner's lesions? Again, on our website, icnetwork.org, we have a whole section on Hunner's lesions. We now consider Hunner's lesions its own unique disease. It's called Hunner's lesions disease. I actually have a website on it, hunnerslesions.org. Around the world, there is a strong movement to split off Hunner's lesions from this normal group of IC patients because they believe you deserve your own research, and I agree with that too. There are really only 4 treatments for Hunner's lesions aside from diet and stuff like that. So if you have Hunner's lesions, you've got big bloody wounds in your bladder. When they biopsy a Hunner's lesion, it is filled with inflammation. There is a massive war happening in your bladder. And it was researchers in Europe who made a remarkable discovery that some patients with Hunner's lesions have a viral infection in their bladder wall. The specific virus is called Polyoma virus. Polyoma is a virus we all have. It's part of the virome. It's part of our normal human biome. We call it the virome for viruses. And normally it doesn't do anything. It sits there quietly until you get immune compromised. When you get immune compromised, that virus turns on and it can cause a lesion in the bladder. And that lesion is known for bleeding profusely. They call it a waterfall effect. It can bleed like a waterfall. So we also know there's another theory that lesions are caused by neuroinflammation. And then we have a brand new case study that I published on our website maybe about 6 weeks ago of a woman who had severe Hunner's lesions, but she also had a severe prolapse. And so when they went in to repair her prolapse, what they found was that one of the tendons that anchor her uterus, or let's see, it's easier for me to do it it's easier to do it this way. So normally, if this is your uterus, there's a tendon on this side and a tendon on that side. that basically hold your uterus in place. One of them had snapped, and her uterus had rotated backwards. It was facing the wrong direction. And when they restored that and got her uterus in the back direction and got it reattached properly, and they restored or corrected the prolapse, they were stunned that her Hunner's lesions healed completely. So again, we can't make any blanket statements that everybody has this or everybody has that. There is tremendous diversity in this patient population. So in her case, her Hunner's lesions appear to be caused by a twisting motion in her pelvis, which probably pissed off a couple of nerves, which may have triggered the lesion. That's my guess, at least. So how do we treat lesions? Number one, cauterize them. We want to seal that wound so urine is not getting into the wound and irritating it. So they can cauterize it with either a laser or with another device. They call it a fulguration. That's number one. Number two, they can inject it with a steroid. If you inject it with a steroid in the middle of the lesion, it calms the inflammation down. Or number three, hyperbaric oxygen therapy has been found to be helpful for the treatment of Hunner's lesions, where you basically go into a chamber. This is what they treat the bends with for scuba divers who come up too quickly and they have issues with oxygen. Something bubbles in their blood. I don't remember what. Anyway, they put you in a hyperbaric oxygen therapy chamber, and that forces oxygen into your bloodstream. And so we have some research that suggests that can be helpful for lesions. And last but not least, we have Liris, Liris, which is the only treatment in history that has healed lesions completely in just 2 weeks, and it's not available. Allergan is sitting on it. And that's a kind of like a crime against the icy humanity. So Elizabeth says Euro gave you the choice of steroid injections or fulguration. You chose the steroid injections. I think that's a good start, because the steroid injections are not going to physically damage your bladder at all, whereas the fulguration will leave scar tissue behind. And so it would be very interesting to see how you do with that. Alan says, don't know if it's only me. My scan results say that the wall of your bladder is rough. Oh, So there is an area of your bladder called the trigone, and it goes from your ureters down to your urethra, and it's different tissue. And the trigone is known in some patients to have a cobblestone-like appearance. It looks like cobblestone. It's very rough. And there was a lot of debate 20, 30, 40 years ago about, is that normal or not? And some doctors thought it wasn't normal and they cauterized it off. Others said perfectly normal, nothing to worry about. And the last time I read up about it, the general consensus was that the cobblestone was fine. As long as you weren't actively symptomatic, they weren't particularly worried about it. Danielle says, antibiotics ruin my system. Antibiotics take a toll, no doubt about that. We have to work hard to restore it. This is why I am having a yogurt smoothie. Coconut milk yogurt. I don't do dairy yogurt. I do coconut milk yogurt. It's wonderful. Elizabeth says, I believe I have neurogenic bladder due to repeated bladder procedures. I had an aggressive hydro, and I believe the nerves in my bladder are permanently damaged. I've also had repeated catheterizations, and I believe it created urethral dysfunction. I'm scared that with the repeated procedures, I'm doing more damage to my nerves. I cannot start a urine stream. Okay, so Elizabeth, number one, I'm sorry you're going through that. Girl, you're not alone. You're not alone. But you know what's so interesting here is you haven't said muscles at all. And I would want to know what's going on with your muscles. If you cannot start your urine stream, it might be because your muscles are very tight, because you've had a lot of procedures. You've been in a lot of pain over the years. and your muscles might just be really locked down. And for all we know, I mean, this is why you can't ignore the muscles. Um, there are some patients who they focus on bladder, 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 and they do everything for their bladder, but they're still suffering because they completely ignored their muscles. And vice versa. There are some patients who do muscle, 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 but they're not following the diet to protect their bladder. You have to do a little bit of both. So the fact that you can't start your urine stream is really important. And I would want to know why. And I would absolutely want to know what's going on with your pelvic floor, like your levator muscles, which wrap around your urethra. Brandy says, "Oh my God, I broke my tailbone twice. First time at age 10, second time giving birth." Yeah. Yeah, so, again, very remarkable story that I told in our magazine, I think about a year ago, of a patient who attended one of these meetings. And, I always say, you are an anatomical mystery to be solved. She took that seriously. She went back to her urologist and said that she thought that she had IC subtype 4 pudendal neuralgia. She had pain when she sat down that was relieved by standing up, and she had the pins and needles sensation, maybe a little bit of numbness, whatever. She thought she had a compressed nerve from tight muscles. And the doctor agreed with her, absolutely said, I think you do too, because her symptoms were very positional. Again, when she sat down, it hurt. When she stood up, she was fine. So they ended up doing some sort of visualization imaging, so X-ray, whatever. And what they found was that her tailbone, she had broken her tailbone, and it was healed out of position. So normally your tailbone tucks under, right? It tucks under. And if you look at my early videos, I used to demonstrate it like this because I was trying to do the opposite of the video. Anyway, understand it tucks under. It tucks between your legs under. Her tailbone stuck straight out. Didn't tuck at all. It stuck straight out, and it was crooked. It wasn't straight down, it was crooked. It was really out of position. So think about what that would do to the muscles that are attached to that. The muscles on this side would become overstretched. The muscles on the inside would be bunched up. It wouldn't be balanced. It wouldn't be healthy. So over a period of a year, she worked with a physical therapist, and she actually worked with a chiropractor. I think chiropractic is way too aggressive, personally. I I I I won't do it because I have ruptured discs in my back, but that was what she did. She worked with a physical therapist and a chiropractor, like, weekly for a year, and every time her tailbone went out of position, they put it back in position. Well, a year later, it stayed in the right position. Her symptoms went down 95%. For the first time in years, she was better, and she was so much better, she had a baby. So really, we're looking at orthopedics now for patients with bladder issues. If your bladder's normal and they don't see anything visually wrong with it, it's time to take a step back and let's look beyond the bladder and let's see if there's something else going on. Peony says, "I'm doing both, but it's been 5 weeks and not much help." Peony, you did both of what? 5 weeks isn't enough. Whatever you're doing, understand the pelvis, very complex. If you've had long-term muscle tension, you're gonna be doing physical therapy for a couple of years. Peony says, "Very strict on my diet and doing pelvic physical therapy for 4 weeks now with very minor improvement so far. My doctor said my obturator internus was spasming. Does that have to be treated internally?" Absolutely. That muscle is on the inside of the hip bone. They have to do it internally. And the fact that it's spasming and your doctor's confirmed that it's spasming, that is great. It's great that your doctor saw that. My levator ani spasmed for months and months and months after my hysterectomy. It's brutal. I would be interesting to maybe see if what the doctor would think about you using a muscle relaxant too. I had to use a muscle relaxant. Well, I still use a muscle relaxant almost every night. Wait, your physical therapist only does external work? Yeah, no. No. That's probably that the most effective therapy is a finger up there. Let me get my model. And you guys, I start I started a new physical therapy routine for my thighs, and I'm so sore. But at least my levators aren't spasming. Now it's my thighs. So I'm walking wounded here. Oh, it's just like so bad. Oh, dear gods. I look fat today. I look fat. I don't know why I look fat, but I do. All right. Oh, well. Oh, sore. Sore, sore, sore. All right. So let's get our model out. All right. So peony. Hello, pelvic floor muscles. You see how they're inside of the bones? You see that? So the best pelvic floor physical therapy is a finger in your vagina that are touching these muscles, that are working on these muscles directly. You can't reach them from the outside. So I think it's probably time to ask for a referral to somebody who does internal work. I have my database open. She says, you do not look fat. Don't talk about my friend like that. Okay, just keep saying that. All right. I have my database open now. I've got the Harvard Pelvic Pain Database open on my computer. If you want to tell me where you are, I'd be happy to look it up for you and see if we can find somebody who has the proper training. There's a special certification by the Herman Wallace Institute that if your physical therapist has that, that's gold. All right. Betsy says, on the bladder tracker, is there a way to go back and enter a time that you left out? I don't think so. I don't think so. I think you're just going to have to add that in the notes. Jody says, now you make me think all of my bladder issues have been because of my lower back. I just got an MRI on my lower back and I have degeneration and herniated discs and inflammation in the SI joints. Hello, sister. Jody. Yeah, girl. Yeah. You know, the book you need to get. This is the book you need to get. I should have taken an Advil before I started this meeting. Or Tylenol. Jody. Breaking Through Chronic Pelvic Pain. This is a master class in the pelvic floor. This is the book that really pounded away at joints. You know, so Dr. Jerome Weiss, who's the author of this book, was a urologist who back in the, I think, late 70s, early 80s, somewhere in there, he realized very quickly the bladder therapies didn't work. And that fascinated him. It's like, if this is a bladder disease, why aren't bladder therapies working? So he started looking. He was the first urologist to be kind of humble enough to say, maybe I don't know enough about other structures down there. And so he became a master at muscles and fascia, right? So he went beyond the bladder and was looking at everything else that could influence the bladder, right? And so he became the national expert, probably for the time, at the bony structures and the muscles. But what baffled him, and again, if you walked into his clinic with tight muscles and trigger points, you would walk out after therapy with fairly normal muscle tone. But what baffled him is, why did it come back in a week? Why did the muscle tension come back in exactly the same spot? Like Jill, why is Jill's muscle always tight right here? No matter what he did, a week, 2 weeks, a month later, bam, it got tight again. The trigger point came back right there. And so that's when he went, okay, we need to take a step back from the muscles and let's look at the bones. Let's look at the bones, because it's bones that put pressure on muscles, right? And so it kind of makes sense. I mean, seriously, If you look at the SI joint, so here's your SI joint right here. It's where your hip bone attaches to your sacrum. It's back here, and it's normally held together with muscles and ligaments. But if your joint has become flexible, that means that the ligaments and the muscles aren't holding it together quite so well. And that muscle will then have to work harder and it will get tighter and tighter and tighter. And every time you move, the joint flexes, that hurts, your muscles lock down. SI dysfunction, right? Which you have and I have. So it kind of makes sense that if you have a bad hip, that could tweak your pelvic floor, because if you got a bad hip, you're limping, you're walking like this, right? It makes sense that if you have a bad SI joint, your pelvic floor is going to be unusual, because again, it's your pelvic floor that helps keep that joint together. And it also makes sense that if you have a bad knee, of course, your pelvic floor is going to be traumatized, because again, when you're walking, you're going to be right. And even though I'm wearing a knee brace, I don't have a bad knee. I have to wear that for a nerve, believe it or not. But here's the thing. He made one final discovery before he retired. And what he found is that in 95% of his patients who had extremely tight muscles, that no matter what they did, these muscles stayed tight. It related to how they were walking, that they had a bad foot, that they were rolling an ankle, or they were pigeon-toed or duck-footed. And this is a really good illustration of what they found in some patients with long-term chronic pelvic floor tension. So here, I want you to look at this for a moment. So here's a normal ankle, and you're going to see that it basically travels straight up. We don't see, we just see normal muscle tone. Sorry, I'm not describing this well. Okay, but look at this ankle. Look at this leg where the ankle is rolled in. Instead of the forces going straight up, look what happens is the forces go up at an angle. And if you look closely, you will see that the muscles on this side are stretched out and they are getting tight and dysfunctional. So look at the difference. This is the forces go straight up versus if you roll an ankle, the forces go off to the side. So that's going to tweak your pelvic floor. One of the patients that I've worked with whose muscles are like, her muscles are like cement. I mean, she is suffering. It is awful. And they can't fix it. And the reason why they can't fix it is because she has a club foot. She was born with a club foot. She cannot walk normally at all. And so, again, in his case, what they found, here we go. Let me read you a couple of these success stories in here. I mean, this book is insanely good. And it's free on Kindle Unlimited. Like, no excuses, guys. For God's sake, it's free on Kindle Unlimited. If you don't get it on Kindle, you can get it in our store for $29. It's $35 or $36 on Amazon. Okay. Case number one: a 50-year-old man had been seeing me occasionally over a 10-year period for intermittent perineal pain. I'd been treating his tight pelvic floor muscles and trigger points with internal manual therapy. Though he received great relief from these treatments, pain flares inevitably occurred. Frankly, I'd never completely understood the mechanics of his symptom flares until he came in one day complaining of hip pain while walking over hiking trails. This led me to question him further and ultimately put us on the right track. I asked him if there were any other musculoskeletal problems that he had not thought to mention previously. He responded that he always had pain at the base of his large toes, which he attributed to arthritis. But because he knew that other family members had the same problem, he never sought attention for this quote unquote congenital issue. I then examined his feet, something I had not been accustomed to doing, and found small bunions and moderate overpronation. At that moment, the light went on. I found the origin for his hip pain and also his intermittent perineal pain. So, like, there's a structure here, guys. So these are the for a woman, and I don't have a male model. And for the men watching, I'm so sorry, I can't even buy one. So bear with me here. This is going to apply to you too, even though I know you don't. I know this doesn't match, but between your vagina and your rectum, or the base of your testicles and your rectum, is something called the perineum, right? The perineum. Now, when I was in high school, I had quote unquote vulvodynia, and it was always right there. And it felt like somebody had scrubbed my skin off with sandpaper. I mean, it was really bad. And of course, they're all going yeast infection. Some doctors said you're red. Other doctors said you have the most sensitive skin in the world. Dr. John Renfrey, thank you. And it was always right here. He explains that in this book, that immediately above the perineum is an attachment point for 4 muscles. It's a muscle tension area. It's like, no wonder. All right. Let's do another one. A 65-year-old woman came to see me with a history of recurring urinary frequency urgency and urethral pain without infection. Examinations revealed tight hip rotator muscles with trigger points. I released the trigger points with internal manual therapy, to which she responded positively. However, she continued to have pain flares. While my treatments were effective in the short term, the results only endured for variable periods of time. So I continued to administer therapy for about 10 years. At the time of her last visit, armed with new knowledge, I looked at her feet and noted unusually high arches. When I asked her if she had experienced any potential side effects, she came out with bilateral Achilles tendonitis, knee surgery, and more recently, hip pain when awakening and rising from the crouching position. In my mind, I visualized a straight line of mechanical stresses. It began with the foot imbalance, which affected the Achilles tendon, then the knees, then the hips, and ultimately the pelvic floor. A visit to the podiatrist was the last stop on her healing journey, and it is unlikely she will require many, if any, additional sessions with me. 10 years ago, when I first saw this patient, the feet seemed too distant from the pelvis to be considered. Experience has taught me otherwise. I'm going to do 2 more because this is important. Okay, here's another one. Here's another case. 42-year-old man with voiding difficulty reported that age 14, he had severely fractured his left foot, leaving him with a short leg. Since that time, he had assumed many abnormal positions when sitting to protect the leg. Within a year or so of his injury, the voiding difficulty began, and he was too embarrassed to mention the problem to his parents until another year passed. He was subsequently found to have tightness of the pelvic floor muscles, which is typical of voiding problems, and had limited success with manual therapy and biofeedback. When I examined him, the short leg was apparent, as well as externally rotated legs and a severe overpronation of the feet. A visit to the podiatrist proved to be the missing link in his treatment. And last but not least, a 31-year-old woman came to me complaining of vaginal pain during sex. This symptom was completely alleviated with manual therapy for the tight muscles and trigger points of the internal hip rotators. However, the patient began noticing vulvar pain when she exercised, which I surmised had been there all along, but was masked by the predominating vaginal discomfort. Not infrequently, localized pain responses present themselves in the order of magnitude. Only when the initial discomfort clears will the patient can become aware of subsidiary stress. So when I re-examined this young woman, I found nothing in the vicinity of her pelvis that might cause vulvar discomfort. However, this time I scrutinized her legs for clues to her new symptom and noted extremely high arches, which were no doubt the cause of the previously noted hip trigger points. And again, it referred her to a podiatrist who fitted her with orthotics, and the vulvar pain completely disappeared. This was one of the cases that led me to realize the importance of a routine biomechanical assessment at the time of the intake examination. So again, I want you to look at this picture here. Look at this picture. You can very clearly see what happens when you're not walking correctly. In this case, the ankle's turning inwards, and rather than the forces going straight up, they're now going at an angle. and that is putting stress and pressure on this side of the pelvic floor. When they fix that, we're going to see a leg like this. Somebody's walking balanced now. The obturator internus muscle and the sacrotuberous ligament tighten and can trap and injure the pudendal nerve. And the obturator is right there, but and it's kind of mixed on that model. All right. You know, whenever I do these meetings, I can't talk afterwards. All right. Elizabeth says, I have 100 lesions, but the rest of my bladder wall looks normal and healthy. It's not small or stiff or shriveled. Too bad. I just have those 2 gaping open wounds. So, Elizabeth, sometimes they actually can cut those out. They do a resection and they just cut them out and stitch it back together. That is a treatment option. It's more severe treatment option, but it has been done. Jean says, how long do you believe taking high-dose long-term antibiotics is safe to continue? I'm 15 months in treatment, no better. Some people do get better, and so it does work for lots of people with infection. I'm in the UK. You know, honey, the American Urology Association specifically excludes the use of long-term antibiotics for the treatment of IC. They say they should not be done. Our challenge here is that you are in the United Kingdom, and you've got Dr. James Malone Lee, who is quite outspoken, who believes that IC isn't a real condition. He pretty much believes that everybody has chronic infection, and that everybody needs to take long-term antibiotics. I mean, that's a little bit too sweeping, but let's just say he promotes the use of long-term antibiotics. But Jean, you're raising the absolute critical point here that we've seen for the last 30 years. And that is, how long do you take them? You've taken long-term antibiotics for 15 months. 15 months. And it hasn't worked for you. And so at this point in time, I would be thinking is maybe it's not bacterial. Maybe it's not bacterial for you. Maybe it's something else that's triggering the symptoms similar to UTI. And again, I would want to know what's going on with your muscles. I would want to know any other conditions which could be contributing to this for you, hon. Janet says, my doctor's sending me for an MRI of my SI joint. I had a fall a year and a half ago, and hurt my left hip. Since then, it's been getting progressively worse. Pain in the perineum, left side of my vagina, along my left groin. So you're saying it is our feet. We need orthotics. Well, it could be. The feet could be part of the issue. But SI joint dysfunction also is the most common injury in racket sports. So it could be injury also. I mean, you fell, hun. And when you fell, you might have tweaked that joint. What is the title of this book? Breaking Through Chronic Pelvic Pain. But what he's saying in this book is for those people who have long-term chronic tension. Whoops, hold on a sec. I just screwed up Facebook. For those people who have long-term chronic tension and you're not responding to, I mean, the therapy is working, but the tension comes back over and over and over and over again. That's when we have to take a step back, look at the bones, look at the hips, the SI joint, the knee, and last but not least, the feet. Lavelle says, interesting. I had a stroke on the left side, which left me with a spastic left side, which is where I have my most burning pain. I'm currently on Elmeron, getting too expensive to take 2 a day. Lavelle, do you know about Elmeron and its problem with the eyes? I don't know many people who are staying on Elmeron at this point in time because we have a very clear connection to potentially very, very serious eye disease. It's called pigmentary maculopathy. So do you know about that? If you don't, I will explain it to you. Lisa says, should we see an orthopedist? Yeah, absolutely. Or a physiatrist. A physiatrist is somebody who specializes in muscles and bones. If your muscles continue to stay tight, there's nothing wrong with letting somebody evaluate the structure. Again, you are an anatomical mystery to be solved. We have to study your pelvis, everything in your pelvis, not just your bladder, to see what else could potentially be driving your symptoms. Yeah. So again, if you had a stroke on your left side, which is where you're having the most burning pain, that's very, very interesting. Lavelle, I haven't worked with a lot of stroke patients, so I got to be perfectly honest there. I would be happy to dive into that a little bit with you if you want. We can maybe reach out to a couple of the top doctors and see if they have any insight for that. I would be happy to do that for you. Again, guys, if you need to reach me, icnetwork@mac.com, icnetwork@mac.com. Carol says, is ibuprofen a trigger? I'm on them for nerve pain in my back. It's taken away my back pain, but my IC flared, vicious circle. Some people have found the NSAIDs to be triggers. So whether it is ibuprofen or whether it is Tylenol, there's a small school of thought that believes that that can intensify pain. But there are others who disagree with that. You have to figure out what works for you. It would be very interesting for you, Carol, to consider something called palmitoethanolamide, PEA. PEA. PEA has been used in Europe for over 20 years. It's been studied with many, many pain conditions, especially neuropathic pain conditions, from fibromyalgia to sciatica to burning mouth syndrome. They've studied it with acute pain. They've studied it with chronic pain. And 2 years ago, they did an IC study. And the IC study was remarkably successful that by month 3, 87% of patients reported a significant reduction in their pain. And by month 6, some of those patients were now completely pain-free. The consensus about PEA, which is a very simple fatty acid, no side effects reported in the IC study or in the great majority of studies out there, very easy on the body. The general consensus among the researchers is that it's the best at calming nerve pain down. And so that would be very, very interesting, maybe for you to consider instead of the ibuprofen, maybe So, people ask me what I do, and of course, what I do may not have. Here, hold on a sec. What I do has no relevance to most of you because, we are all unique. But I am IC subtype 5, central sensitization, and IC subtype 3, pelvic floor. So, for my pelvic floor, I do a lot of muscle work, and for my central nervous system, I take Peora. Peora, which you can get in our store, and it's remarkably inexpensive. It's $24.99 for a month. I always know when my nervous system is getting triggered, my central nervous system, because I start feeling pinpricks randomly. I'll get it on my leg, I'll get it on my back, my shoulder, my stomach. Trying to go to sleep when that's happening is very hard. And amazingly, this has turned most of that off. It did happen last night. I was trying to go to sleep. And then I realized that I had just washed the pajama top I was wearing, and I took the top off. It went away. And so that's a sensitive skin. But anyway, Peora, PEA, would be very, very interesting to consider for those patients who have nerve pain. And I will give you the link so that you can do your own research. Hold on a sec on Facebook. Yes, there is permanent damage caused by Elmeron to the eyes that they believe now. Patricia, hold on one sec and I will tell you. Okay, so on Facebook, here is, I want you to copy and paste this. That's the scientific name, palmitoethanolamide. And I want you to go to pubmed.gov, which is the National Library of Medicine. I want you to copy palmitoethanolamide into National Library of Medicine, and you look at the studies. It's great. Very, very promising. I mean, we've had pharmacists bringing in PEA for IC patients for about 20 years. The challenge is it used to be really, really expensive. Deborah says, my urologist, when asked about the eye problem with Elmeron, said only about 7,000 people have had trouble with their eyes. She recommended I stay on it. I'm confused. Could allopath be helpful in replacing? I think Bladder Builder, you want to go for a chondroitin-based supplement first because it's chondroitin that previous research studies has been found to restore the superficial integrity of the bladder wall. So the direct replacement for method of action to Elmeron would be a chondroitin-based supplement. So that's Bladder Builder, Bladder Rest, Cystomen, Cystoprotect. Those would be the 4 primary ones. I don't know where the urologist is getting that 7,000 figure. I think I would want to know the source of that. I just talked Friday with one of the other lead attorneys in the Elmeron case. And it is progressing not only in the federal courts, but also in the state courts. Our challenge here is that the statute of limitations is rapidly appearing. So for some people, you're already past your statute of limitations, depending on the state that you're in. So if you've taken Elmeron and you have eye issues, you better damn well, and you want to be participating in some of the litigation, which I think is fair, you're going to have to act quickly. There's a website, elmeronlawsuits.org. That's a group of firms that I've worked with for over 2 years. But there are a lot of attorneys that are working with patients now. The last I heard, there were over 500 cases that have been filed. I'm sure there's subsequently more now. Our research study, small informal research study, showed I've got 2,000 patients in that study. 54%, 54% of Elmeron users in that study report retinal disease. Jennifer said the involuntary movements that I have in my right ankle and foot could be causing me problems. Maybe I have essential tremor. So, I mean, you sometimes see when I'm doing these meetings, you see my head going like this. That's just my neck is super, super tight and I have essential tremor. I get it in my legs too. I have it in my right leg right now because that's my weak leg. Okay, so let's for those of you who are late, let me bring you up on the big news. The super, super exciting news now is that Wake Forest University, the home of Dr. Robert Evans, the doctor who's been voted Doctor of the Year every year we've ever had that. We haven't had it for 2 years because of COVID, but his patients love him. The great majority of his patients love him very, very much. Dr. Evans has also been participating in some of their bladder research. So the question a lot of patients have asked me over the years is, well, can I ever get a new bladder? And the answer is we don't have bladder transplants to any great degree. Usually if there's a problem with the bladder, they remove your bladder and they put a stoma in, they connect your ureters to a stoma and your ureters would drain directly through the stoma. But about 10, 15 years ago, they started Wake Forest, the Institute for Regenerative Medicine, were the first in the country to successfully create real bladders or bladders from real tissue. And so what they would do back then, because I wrote a bunch of articles on it, it was so cool, is they would do a big punch biopsy and they would get all 3 layers of the bladder from the inside all the way to the outside. Then they would grow each layer out independently. So they would have a layer of urothelial cells, they would have a layer of gag layer cell, whatever. And then they would have a layer of the smooth muscle, right? So they would have each layer is growing independently. Okay, so we've successfully grown out the tissue. How do we make it into a bladder? Well, what they did is they used a scaffolding, a scaffolding that was composed of tissue completely normal in the human body, would not have caused any sort of reaction like that. So they put the outer part of the bladder cells on the outside of the scaffolding, and then they put the urothelial cells on the inside of the scaffolding. So now we have a scaffolding in the shape of a bladder that's growing tissue. So they were able to create a real hollow bladder, right? But the ultimate challenge is blood supply. So now we've got, in the shape of a bladder, we've got good cells. How do we get a blood supply? And so what they did is they wrapped it in omentum, which is very it's on the inside of your abdomen, and it's very involved in your circulation and delivering blood. So they wrap these artificial bladders in omentum, and they actually implanted them in children with spina bifida to great success. Really, really good success. So, but they were children and they were not IC patients. And so now Dr. Evans interviewed me. I mean, he didn't interview me. He sent me an email yesterday announcing that they are now doing a study where they're asking for human volunteers. So let me just read his email. This is truly, truly mind-blowing. This is like the biggest research announcement maybe in the last 50 years, really. So he says, "Hi, Jill, I'm writing to you. I'm writing to see if you would be interested in putting something out over the network. I'm involved with the Wake Forest Institute of Regenerative Medicine. We have been granted permission from the FDA to proceed ahead with the next phase of our bladder regeneration project and are looking for patients, plural, patients. Specifically, we need someone with a small bladder capacity under 150 with severe frequency who would be willing to participate in this bladder regeneration project. They would have to agree to undergo a procedure where we would first remove a 1 to 2 inch square piece of bladder. This would then be processed and the cells would be placed on a scaffolding, and it would then grow to about a 500 ml capacity. In other words, a new piece of your own bladder tissue. We would then use this to enlarge the bladder. The hope is that we would see a drop in the number of voids per day since the bladder would be so much bigger. This would not be for someone who has pain but does not have a small bladder. The ideal candidate would have what we in my lab refer to as a bladder-centric phenotype without other systemic manifestations. Initially, I did not think IC patients would qualify for the study, but I have discussed this with everyone involved. Based on the criteria set by the FDA, there is no reason someone with IC cannot be considered for inclusion as long as they meet the criteria. If someone is interested, they would have to be in our area, which is North Carolina, or move here for the study. But if they do, we can help them find accommodation. So if anybody is interested in learning more about this study or participating in the study, I need you to email me, icnetwork@mac.com, and I will forward you his personal email address and phone number. He wants to talk to you. He wants to talk to patients who might be interested. But again, I'm not going to put that out publicly. It's only if you email me. So please, if you have any interest at all, even if you don't know if you qualify, email me, icnetwork@mac.com, and I will send you this email with his contact information. Okay. Very exciting, like massive. You understand the benefits and advantages of using your own cells to create another part of your organ. We now would not have to worry about rejection. You would not have to take anti-rejection medications. It could be absolutely game-changing. And again, they've already done it with children. They've already done it with children with spina bifida. So it's not like this is brand new. So it's very, very, very exciting. Hi, Card Steve. Card Steve's on YouTube. She goes, "Help, honey, we've talked on the phone, right? We spent a lot of time on the phone." So she says she's been left with rectal and skin breakthrough following pelvic radiation for a large inoperable uterine cancer mass. Biopsy shows a tumor necrotic factor storm in my body. Pelvic floor muscles are deteriorating, vaginal and rectal atrophy, and sores and more, just left unaddressed by the oncologist following pelvic radiation. What happens to surgical candidates in bladder research studies if they get worse? Um, well, that's a very, very important question for the patient to ask is, are you going to help me through thick and thin? Are you going to help me if this works? Or are you going to help me if this doesn't work? Right. I mean, that's a part of the discussion you have to have with the researchers. Honey, if you are who I think you are, I truly, truly hope that you have some comfort. I hope that you're on some pain medication. And I hope that you found a home for your kitties, honey. I'm so, so sorry what you're going through. Chimera says, to whomever had their urologist tell you to stay on it, get your eyes checked. I can't see my face in the mirror if I close my right eye. All right, so Deborah, that's from Chimera on YouTube. She says, to whoever had their urologist tell you to stay on it, get your eyes checked, get your retinas checked. I can't see my face in the mirror if I close my right eye. I had a patient that I was working with either on Thursday or Friday. I think I told her story in my Thursday meeting here on Facebook. So she heard about the Elmeron eye issue just like last weekend because she watched one of these meetings. And so she called her eye doctor and said, hey, do you know about this? And the doctor just blew it off and said, nah, you're fine. It's just your corneas. It's not your retinas. And so then she called us and she was asking about it. And I said, well, have you had your retinas checked? She said, no. I said, well, you really need to have your retinas checked to really know. A regular ophthalmologist cannot see it. It's a very specific retinal scans that can identify this examination. Then I said, well, let's just look at the number one symptom. Do you have any problems going from light to dark or dark to lightness? And she goes, oh my God, how did you know? It's so bad. I can barely see for 5 minutes. And I'm like, honey, that's the number one symptom of pigmentary maculopathy. Is that you have trouble, your eyes have trouble adjusting when going from light to dark or dark to light. So I sent her back to the retinal specialist to get her eyes checked. Can physical therapy help with bladder burning, or is that more bladder wall related? So when somebody says burning, actually the burning sensation is normally associated with muscles. It's not normally associated with the bladder wall. The only other context is estrogen atrophy. If you are of a certain age, or you are in chemical menopause, or you've had a hysterectomy, and we know you are now in total estrogen atrophy, as that skin gets drier and drier, urine crossing that skin will irritate it. And we call that urine burn. So if you have a burning sensation in your urethra, or more likely on your vulva, so that as your urine is crossing your skin, it feels like it's burning you, that's estrogen atrophy. But if you have a deeper internal burning, we really associate that more with pelvic floor spasm, because a muscle that's working hard is a muscle that builds up lactic acid, and that burns, that deep burning sensation. Okay. Mandy says the United Kingdom is so behind with the IC. What's amazing, Mandy, is you guys had the most amazing nonprofit run by Annette and Anthony Walker called the IC. What was it called? Well, it was your national IC group. And unfortunately, it just broke down. A lot of different things happened, and the group virtually died. There was a divorce, and then there was partisanship, and it just it just pretty much died. Thankfully, right around the time they were going to close it, another group of patients stepped forward and resurrected it. And it's now known as Bladder Health UK. And they work not just with IC, they work with a lot of bladder conditions. And so, make sure you go to the Bladder Health UK website. They do offer support. And what they do that no other country does, by the way, is they actually have a phone line manned by nurses, I think one day a week, where you can call and talk to a nurse about your IC. But yes, otherwise, the United Kingdom is remarkably behind. They were very slow in incorporating pelvic floor work and stuff like that. The challenge with both the United Kingdom and Canada is that your healthcare system is really controlled by a couple of doctors at the top. I flew to the United Kingdom with Dr. Marshall Stoller years ago, and we went on to on BBC, and we met with a whole bunch of doctors over there because we were talking about the ankle stimulation. And what we were told was that there's basically like 3 urologists who control the entire country. And if those urologists' beliefs do not include interstitial cystitis, then interstitial cystitis is not going to be emphasized. Now, this was like 20 years ago, but it is what it is. And I was working with a patient in Canada who had to wait a year to see her urologist for a severe flare. It was just stunning. Marlia says, when we pee so much, we have to wipe so much. The area that gets wiped almost feels chafed. Is there something to use, vaginal cream or lotion, that can relieve the soreness that will not cause a UTI? Yeah, coconut oil. You can use coconut oil, but the challenge with coconut oil is it's fairly messy. And so if you're going to use coconut oil, normally you would use it at night, because during the day it's going to soak through your underwear, and it's literally going to reach your pants or your dress, and it's going to get a darker oil stain on it. The other thing you could do is V Magic, V standing for vulva. And this is made by a company called Medicine Mamas. And the cool thing, I demonstrate this all the time. It's hysterical. So, it looks like Vaseline, but it doesn't feel like Vaseline. It literally is the lightest product that feels almost exactly like human mucus. I mean, it's so light, but it's just got that enough of an oil to kind of coat that skin and protect that skin. And so V Magic would be my other suggestion. If you're going to go the coconut oil route, just go to your local store, but get an organic, extra virgin, cold pressed olive oil. I mean, coconut oil, not olive oil. This has olive oil. This has, let's see, this has extra virgin olive oil, extra virgin avocado oil, extra virgin, not extra virgin. It's got sea buckthorn oil, honey, and propolis, right? And a lot of we sell a lot of this in our store. It's very, very popular. So V Magic. Okay, somebody's looking for Georgia. And I'm sorry for not doing that more quickly. Normally we look up doctors towards the end of the meeting, but let me just look at Georgia here real quick. Advanced Urology in Atlanta, and then you also have Dr. Denise Pecht, Pecht, outside of Atlanta. There's quite a few physiatrists. Well, there's 2, not quite a few. Pelvic Rehabilitation Medicine in Atlanta, the Harbin Spine and Pain Management Clinic in Cartersville, and a bunch of physical therapists. So we can do more of that later. Well, you guys, the Zoom, we didn't do the Zoom. Oh, well. Marie, thank you for the 100 stars. 3 weeks in a row. I really appreciate that. How do you find out if you have estrogen atrophy? I went through menopause in 8 weeks while having chemo for breast. Honey, you're there. I mean, um, uh, do you still have your ovaries? Are you still having your period? If you're still having your period, then you might be in perimenopause. But once your period has stopped, you're in menopause. Lavelle says, I had a total hysterectomy, been on hormone replacement for years, has not helped. Yeah, you guys, you got to have a reality check here. You got to have a real big reality check about your expectations with hormone use, estrogen use. So when you're using a topical hormone, you're not necessarily going to feel better right away. It's not going to fix your frequency or urgency. What it is doing is it's giving your skin what it needs to produce mucus. And so some patients stop using it after a month or two because they go, well, what the hell? It didn't do anything for me. You kind of have to take a step back from that and ask yourself, what is healthy skin? What is healthy skin? Healthy skin down there is moist skin. Your bladder, your urethra, your vulva, and your vagina are mucous membrane organs. They are meant to be moist. And so anything that you can do to improve that moisture is important. Lisa says, pat dry, don't wipe, get a $30 plastic bidet. Oh, or a peri bottle. Yeah, here, hold on. Let me give you an example. All of our members get one for free. Oh, I'm so sore. There you go. Ooh. I was doing a lot of squats yesterday. Oh, I'm so sore. It's ridiculous. Peri bottle, your best friend, woman or man or woman. The peri bottle is critical because so what you do is you fill it up with water and you just leave it next to your toilet. And before you use your toilet tissue, rinse yourself off with water first, just room temperature water. Because remember, toilet tissue won't wash all the bacteria off of your skin, but water will. Water will be more effective at that. You're not using a soap. You're not putting anything into it. You're just rinsing yourself off with water and patting dry, right? And if you have urine burn, so your skin is really, really dry, and you hate peeing because you know it's going to hurt, fill this up with cold water and then just rinse yourself with cold water while you're peeing. I did that all the time. And it helps tremendously. So these peri bottle, obviously, it just has a normal top. I don't know if you could see that. So you just squeeze it, and the water comes right out the top. They're $2.99 in our store. You can go to a medical supply store; they might have it. But again, no chemicals. It's just water. Okay. So if you've got vulvodynia, any skin sensitivity down there, anything like that, this is what you need. Jana says, what if we react to chondroitin? What else can we do? Take aloe vera? Well, aloe vera is one option. Yeah, it would really be your only other option for a bladder coating would be an aloe product. So I like Allopath because Allopath combines organic anthraquinone-free aloe with PEA for pain relief. So it's like aloe with Peora in it. And I just think it takes that soothing effect another step higher. Karen says, what email is best to use? icnetwork@mac.com. icnetwork@mac.com. Facebook, I'm going to put it right in there. If you think you might be interested in participating in this groundbreaking study, email me. Deborah says, I'm on Premarin. Why do we have to stop for 1 week and then restart? Well, Deborah, it depends upon your age. They might, if you're still younger and not having a period, are you still having a period? They might have you stop to kind of I don't know, force a period, something like that? That's a good question for you, doctor. I mean, I'm on topical estradiol. They never told me to stop for a week and then restart. So I don't know what they're trying to accomplish with that, hun. It might just be to mimic more normal hormone behavior. I don't know. I don't know. All righty then. So our next big event is going to be the International Pelvic Pain Society conference next week. I will be there, and that was a conference last year that taught us about chronic overlapping pain conditions in the brain. That was very, very good. I need to keep reading these books. I mean, I think my memory is pretty good, but when you're doing meetings like this, you always have to reinforce your knowledge. Okay, so this is important. So remember we were talking about the influence muscles over other parts of the pelvis, and how you can start with a little injury that over time will create long-term tight pelvic floor muscles. Honey, thank you, Cardsty. I'm sending a lot of good vibes for you. Use next door for your kitties. All right. So, again, we're quoting from this fabulous book, Breaking Through Chronic Pelvic Pain, a holistic approach to relief. This is in the section called The Ripple Effect of Pelvic Pain. The most significant concept imparted to me by my acupuncture mentors was the need to view the body as an integrated organism rather than as a complex of individual structures. This is the underlying principle of the holistic treatment paradigm. And for the purpose of our discussion, we must apply it to the pelvis. Let's see, as we emphasized in Chapter 8, by virtue of its location in the center of the body, the pelvis influences and is influenced by the upper body, back, lower extremities. So, and he says, picture a continuous connective tissue or fascial sheath loosely overlying all of the muscles from head to toe, like the sheet on your bed. Imagine tugging the sheet at any point and visualize how this causes wrinkles to develop from one end to the other. In a similar manner, mechanical alterations in one part of the body affect adjacent and distant parts. So he says fibrous fascial tissue both separates and connects or binds together muscles, bones, and organs. Therefore, not only is the fascial tissue connected throughout the entire body, but so too are the bones, muscles, and organs, as well as the nerves that supply these structures. These connections are functional. They allow weakness in one muscle to force the surrounding or assisting muscles to work harder. The overworked muscles then become stressed, develop their own dysfunctions, and engage other muscles and structures in the process. To be effective, treatment must therefore address not just the primary problem in the pelvic floor, but also its ripple effect in surrounding and distant muscles, the associated subcutaneous tissue, the pudendal nerve, and the biomechanical structures. Gradually, over the course of my career, I've come to understand and respect the ripple effect of pelvic pain. However, let's see. Anyway, it's such a good book. It's so easy to read. Sarah's story. Sarah came to me at the age of 24 with a 1-year history of urgency frequency. She'd been passing small volumes of urine 12 times a day on average. There was a delay when she tried to start her urinary flow, and once initiated, it was very weak. Sarah also mentioned that she had pain during deep penetration with sex, but the pain subsided if she held still and waited for a short time. And for the past 3 months, she'd been experiencing suprapubic pain, which is pain above the pelvic bone, in bed at night. These symptoms began within 24 hours after an intense orgasm, during a period in which she was under a lot of emotional stress and was holding her urine back for long periods of time while commuting to school. And in spite of the negative urine cultures, Sarah had been treated with 2 courses of antibiotics. And not surprisingly, this failed to resolve her symptoms. A cystoscopy to evaluate her bladder and urethra was performed and showed no abnormalities. However, the procedure itself gave her excruciating pain. My examination revealed trigger points in the adductor muscles of the inner thigh, the rectus abdominal muscles above the pubis, the piriformis muscles, also known as the hip rotators, and the quadris lumborum muscles, which attach the lower ribs and the top of the pelvis. The internal muscles of the pelvic floor, especially around the urethra and urinary sphincter, were markedly tender and duplicated her symptoms when compressed. This indicated the presence of trigger points. Treatment consisted of internal myofascial release of the pelvic floor trigger points and dry needling of the trigger points in the external muscles. The internal and external trigger points of secondary muscle tension quickly resolved. And within 1 month, sex and orgasms were pleasurable, and daytime frequency decreased from 12 to 15 times to 8 or 9 times. After 3 months and 15 office visits, voiding stabilized at an average 7 times per day. So, though slightly higher than normal, this output reflects. Okay, whatever. Okay. Sarah's history includes a string of early trauma to the pelvis that could progressively increase the muscle tension in the affected areas. At the age of 7, she slipped on a large wooden plank and landed on her vaginal area, resulting in bleeding. At the age of 16, she was kicked in the crotch, and at another time was punched in the clitoris. The resulting pain was so severe she was unable to walk for a day. At the age of 19, she injured herself and lost consciousness after slipping on the side of a pool. She was also a gymnast at an early age, and at 19 began dancing vigorously. This resulted in pain down her left leg and low back, which she attributed to an injury of the sciatic nerve. As one incident after another occurred, trigger points formed. All or most of them appeared to have remained asymptomatic. The only indication of a problem was the pain down the back of her leg, which could have been from the piriformis muscle compressing the sciatic nerve, or perhaps active trigger points referring to pain in the area. One day, these tight, strained muscles were put to the ultimate test by a vigorous, prolonged series of orgasm. Muscles around the urethra and the rest of the pelvic floor went into sustained, severe, and self-perpetuating spasm. The result was urinary frequency, diminished urine flow, discomfort above the pubic bone, and pain with intercourse. Sarah's story demonstrates how cumulative stresses and traumas to the pelvis can explode into severe and sustained symptoms when a critical threshold is crossed. It also demonstrates that urinary symptoms are more likely to reflect what's happening outside the bladder than inside. Therefore, practitioners are advised to evaluate and treat accordingly. Additionally and importantly, it illustrates the power of myofascial therapy, which in this case consisted of internal myofascial release and dry needling. No other therapies were required. Perhaps the most important take-home lesson relates to the rapidity of Sarah's recovery. She was only 23-year-old when her symptoms were activated, and only a year had elapsed before she received a proper diagnosis. Her system had not been compromised by many years of inappropriate therapy and unnecessary surgeries, as so many of my patients experience. Thus, her condition did not etch itself into the nervous system and produce a host of associated problems that take years of holistic therapy to unravel and resolve. Breaking Through Chronic Pelvic Pain. Fabulous book. If your bladder is normal, you're suffering with symptoms, but they keep saying your bladder is normal, please get this book and read this book. It is phenomenal. All right. And it's free on Kindle Unlimited. Come on, it's free. Jeannie says, I've used ketchup bottles that you're supposed to put ketchup in from the dollar store. Oh, there you go, instead of these. Jane said, are there physiatrists in BC? I'm sure there are. I just don't have a list of them, hon. You're going to have to call around. If it's not a physiatrist, an orthopedic surgeon, right? Somebody working with orthopedics. I need to stretch. Oh, holy hell. Oh. Everybody just get up and shake it out. Oh, hold on. Stretch it out, my friend. Stretch it out. Oh my goodness gracious. Talk about being tight. My muscles. Oh, hold on. Hold on. Let me go get my thumper. I'll be right back. Hold on. Have you ever seen this? It's a Theragun, and it's hard. This is not a sex toy. This is for physical therapy. Oh, oh, oh. Oh, oh my God. Oh, 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 oh. Wow. Holy moly. Okay. I'm gonna have to stop soon. This is what I get for starting a new routine. Anyway, this is really hard, guys. Okay, this is really just for muscle work. And it works. I think I paid like $125 for it, something like that. But if you can't get to a masseuse or a physical therapist, it works well. It works well around the sit bone and the hip bone. Lindsay said, do you think they may eventually have a bladder replacement study for pain patients as well? You know, I talked to Robert Evans about that years ago. And our challenge here, hun, is that the pain is really modulated at the spinal cord and in the brain. And so the odds of them, I mean, early on, I remember in my local support group, one of the first patients I worked with was an elderly woman up in Ukiah, California, who had had her bladder removed. Then they had told her it was for pain. And guess what? It didn't touch the pain. It did not touch her pain. And that showed us all that her pain wasn't coming from her bladder. Her pain was coming either from muscles or from her nervous system. So I don't see them, unless they could absolutely prove that the pain was coming from your bladder. I can't imagine that they would do that. I mean, because if you have a Hunter's lesion, they would cut the lesion out or treat the lesion. That would be the number one source of bladder pain, right? Janet, thank you so much for the 50 stars. I really appreciate it. And for those of you who are watching, you know, if you like what I'm doing here and you like these support group meetings, please come on over to our website, icnetwork.org, and think about becoming a member, because you would get our magazine. We've been writing, this is our 19th year of producing our magazine. This is our latest one. We're working on the fall one shortly. And in the magazine, we do much more in-depth articles than what you see on our website. These stories will not normally be put on our website for at least a year. So in our summer issue, we feature Callie Krajier, who is a new registered dietitian working with IC patients, who is helping us understand why some IC patients, especially patients with Hunter's lesions who are down to only eating 4 or 5 foods, might end up with malnutrition because they're just not getting enough of the essential vitamins and minerals. And so what she does is she goes over the key vitamins and gives you what they do, the symptoms that happen if you're deficient in those vitamins, and then the IC friendly foods that you can eat that will give you that vitamin. I was working with a patient again last week who, and let me tell you, I went on a rant of rants Thursday. I was in a rant because so we had a 71-year-old woman with severe frequency urgency who found another support group online. And so she went for help because her symptoms were really, 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 really bad. And somebody in the support group said, honey, you need to get your magnesium levels checked, right? Which is ridiculous. It's just ridiculous, right? And she said, you gave her age, what she was doing. They said, "Well, we think it's probably gonna be something related to your magnesium. You need to go have this holistic whatever test, whatever." And she called me, right? And it's like, "Okay, how old are you?" 71. "Okay. When did your symptoms start?" 10 years ago. "Okay, so they started when you're 61, right?" "Yeah." So when someone's symptoms start after the age of 50, the very first thing we're really going to be thinking about is dryness and estrogen atrophy, also known as the genitourinary syndrome of menopause. So tell me, are you dry? And she goes, "Oh my God, I'm so dry. My doctor's just said I'm really, really dry." It's like, okay, so we know what we're dealing with then. We know we're dealing with some really severe estrogen atrophy. And she was up all night, hadn't slept in a long time. Her symptoms were so bad. And I'm like, "Okay, so now we know that you're dry, so we know now that your skin can't defend itself from whatever's in your urine, so now we gotta really think about what's in your urine. So, do you take supplements?" She goes, "Oh, yeah, I take a lot of supplements and vitamins." I'm like, "Okay, what do you take?" Very first thing she said, 2,000 milligrams of vitamin C a day. Holy hell. And that's what I basically said on the phone. It's like, "Oh, no, no, no. Who told you to take vitamin C?" "Oh, I've been taking vitamin C every day for 10 years." I'm like, "Go get the bottle." So she goes to get the bottle. And I said, "Okay, what kind of vitamin C is it?" She goes, "Ascorbic acid." I go, "Oh, God, no, no." She wasn't even doing buffered vitamin C. She was doing the worst vitamin C you can do, ascorbic acid. And then I think she was drinking coffee. Oh, and then she was taking several other supplements that also had vitamin C in it, and only one had buffered vitamin C. And I just said to her, I said, "Didn't anybody tell you to stop the vitamin C?" And she goes, "Oh no, I came to a group online. They said to do it." I'm like, "No, no, no. There isn't a single published paper or study in IC that says that you can do ascorbic acid safely. It's an acid, it scours your bladder. It's the worst thing you can do with estrogen atrophy." And she was like, "Oh my God. Oh my God. Are you saying that this is why I can't sleep?" And I'm like, "Yeah, this is why you can't sleep. If I were doing that and I'm 61, I'd probably be at the emergency room." Can you imagine the corrosive effect of that high level of vitamin C, ascorbic acid on dry tissue? And I was so outraged on her behalf that somebody somewhere in an online IC group told her to take vitamin C. And then the new group that she went to, I won't say who they were, she told them about the vitamin C. They didn't even blink. They said it was magnesium. It's not the freaking magnesium, it's the freaking vitamin C. I was just so outraged on her behalf. So anyway, again, this article, Meet the IC Expert, Callie Crozier, goes over the bladder-friendly sources of vitamin C. What else do I have in this most recent magazine? Let's see here. This is a long story from her. We have the consumer alert about aspartame and cancer. That's what I love to do, is do consumer alert stuff. We now know that aspartame absolutely linked to cancer, no doubt about it. The more you're exposed to, the higher the risk, and that children, even children in utero, who if the mother who's pregnant is drinking diet soda, that infant has the potential of being born with a much higher risk of cancer too. There's new research that came out this summer. That makes sense. NutraSweet is broken down into methanol, wood alcohol. We already know wood alcohol can be fatal if you drink it. Then that's broken down into formaldehyde and formic acid. Formaldehyde is a pickling agent. It's what they use to preserve bodies. I worked with formaldehyde when I was getting my degree, brutal stuff, brutal stuff. So there's people who are undertakers and who prepare bodies for burial, I mean, they have a much higher risk of cancer because of all the formaldehyde exposure. So if you're drinking diet soda with aspartame, you're basically going to end up being exposed to massive amounts of formaldehyde. What else do I have in here? I have a huge article on pregnancy, managing pregnancy in IC. What else do we have in here? Hunter's lesion patient, unexpectedly cured with a ligament repair. Elmeron transition options for people trying to get off of Elmeron. The latest research. Migraines, whole article on migraines, which is related, chronic overlapping pain condition related. Laser therapy for pelvic floor dysfunction. How to combat loneliness, which God knows we're all struggling with right now. That's a whole nother chat. Icy friendly salads, etc., etc. So if you'd like to get our magazine, you can get it for $25 a year if you go on over to our website. The $25 a year is electronic. You also get a year previous, you get 8 total issues. If you do the $50, you get a lot more magazine. If you do the $100, you get like 5, 6, 7 years of magazines. So along with cookbooks and things like that. All right. Mary says, why isn't this translated into Spanish? Because I don't have the money to do that. And we just don't have the funds to do that, nor do I have the volunteers that will help me with that. I've had several people step forward and offer to help, but in the end, they just don't do it. I've even sent, like a 1-page flyer for translation, and it never gets done. Boris says, I remember calling someone on the phone for IC back in the 80s. Yeah, that would have been probably either the ICA California, ICA New York, or there was a separate group in Ohio, and then there was also a separate group in Virginia. They were all answering the phones back then. Of course, they've all disappeared now, pretty much. Rama says, I would like to let you know that I started taking Ortho D Hist from last 1 year, and my horrible IC symptoms have become much better, and I've been able to tolerate different types of foods. Please research more of this. It may be because the D-Hist ingredients act on mast cells. Excellent suggestion, hon. Excellent suggestion. Ortho D-Hist. Let me just, give me a second. Anywhere you have a wounded bladder or a dry bladder, urine is going to penetrate into that skin, just like a mosquito bite. When you get a mosquito bite and they stick their little mouth thing in there, they release a venom. Is that the right word? Well, they release whatever they release that is irritating, and the mast cells in the area release histamine, which then causes the swelling and the pain and the itching of a mosquito bite. Well, that same process happens in the bladder. If something gets into your bladder wall for whatever reason, mast cells are going to release histamine that's going to cause swelling and irritation. And so one of the ways we used to describe IC is that like having 100 mosquito bites at once in your bladder. Now that was before subtypes, but understand that the role of mast cells is important. And that's why antihistamines like hydroxyzine, also known as Atarax or Vistaril, are commonly suggested to IC patients and are listed as step 2 treatment options in the AUA guidelines. So Ortho Molecular Products, Natural D-Hist. Honey, but the challenge with it, I got to tell you, Rama, what's the number 1 ingredient? Vitamin C, ascorbic acid. That's going to be really tough for many patients to tolerate that. Now, the fact that you're tolerating it is interesting. Somebody asked what this is. This is a smoothie that I made with raspberry, coconut milk yogurt, and then ice, frozen bananas, a few frozen strawberries, frozen mango. Remember, the tropical fruits are, especially if they're ripe, are much more bladder friendly. than we first thought. So, but this is mostly banana. It's like half of banana with like 2.5 or 3 strawberries. Vicky, no, that's not. I mean, that's not a prescription. That's an OTC supplement. But again, it's got ascorbic acid in it, so it would not be our first choice. I would look for a quercetin product. So it's got quercetin, stinging nettle, bromelain, and NAC. I would look for one that use calcium ascorbate rather than ascorbic acid. A buffered vitamin C would be a little bit more bladder friendly. Janet says, I've been so depressed the last couple of days because my bladder and hip pain. My husband brought me home some flowers. Oh, isn't that great? I hear you. I know. Life is not for the faint of heart, you know. But you guys, you always have to remember your strength. You have never been more prepared to deal with whatever happens to you than you are at this very moment, because you are truly one day older and one day wiser. You are not going to repeat the mistakes of the past. Embrace your age. You've earned it. Those scars, those difficult times are proud bandages for your resilience. You are tough cookies. Elizabeth says, I went to pelvic floor PT. She does internal work. I've had 5 appointments. She says I had intraoidal narrowing at the entrance to the vagina. I've not been through menopause. I'm young and probably have endo. So, okay. So that's important, Elizabeth. This is very, very good to know now. Understand that muscles respond beautifully to muscle therapy. And in this case, not only is she going to be working, so basically she's referring to your levator muscles. These are your levator muscles right here. And so you have to kind of ask yourself, what is it that's causing the narrowing? And again, usually it's tight pelvic floor muscles. And it would be interesting to know if you've had any other pelvic injury. You should tell her that. Have you ever fallen on your tailbone? Have you ever fallen on your hip? Were you a gymnast? Were you an ice skater? Can you remember any traumas? Where you've fallen, or even sexual abuse, or if you were raped, things like that, that can traumatize the pelvic floor, that could help us then understand why you're struggling with that narrowing at the entrance to your vagina. And what you do at home is important, that normally, I don't know why that guy keeps turning off and on. So normally you would have a wand, and they would teach you how to use your wand so that you can start working on the muscles on the days when you're not at physical therapy, like 5 minutes a day, whatever. I just find this really interesting because, when they first suggested this to me, and I tried it. It's like, I don't know what to do. I'd stick it in there. I mean, I'd lay on my back, stick it in there. Obviously, everything's clean and stuff. Use a little bit of KY on it. But I didn't really understand the mechanics of it because I didn't understand where the muscles were located. And it was really Dr. Jerome Weiss's book that helped me understand more how, how I should be working with the pelvic floor. And then, of course, this model is just excellent. Because what you can see here with this model is that these muscles are supposed to lay flat against the bone. It's not like these are big chunky muscles. These are thin muscles that lay flat right against the bone. What happens though is when they get tight, they lift off the bone. They lift off of the bone and they start interfering with other things that are happening here, right? And so as I've done this, like when I first started and I was dealing with my SI issue, my right side was normal. My left side was very painful, deep. It was tender up here. And I never cried during physical therapy. Understand that, John, Loretta, coconut milk yogurt works like a charm. All right. So I never cried during physical therapy. Never. But I always knew how I was doing by how I felt walking out, and most importantly, sitting in the car, right? And so when you're having the physical therapy, that's just a lot of give and take. You're laying on your back, They're doing what they're doing, and they're really looking at your face because it's your face that reflects your comfort. If you kind of go, then they know they're touching something that's tender. And some people, we just don't talk when it hurts. We get very silent, like my mom just doesn't say anything when it hurts. So they really rely on your facial expression to figure out what's happening. And so again, when we started physical therapy, for me, it was my left side, and it was primarily the deeper muscles way up here. So over a period of time, we got that as good as it was ever going to get until I can get the SI joint fixed, right? But pretty good. But then I ruptured 2 discs in my back a year ago, last December, during one of our evacuations. And fascinating, because rupturing my disc, I didn't know what happened. I woke up, and as soon as I got out of bed, I could tell that my right foot wasn't walking normally. It was like it was asleep, right? So I just kind of shook it out. It's like, all right, my foot's asleep. And so I took I just went to the bathroom, and then I went out to get our paper. And when I stepped down into my garage on my right foot, my leg collapsed. My leg collapsed. And that was like, uh-oh, what the hell is this, right? And I got myself up, went out, got the paper, and my thigh was really hurting. And over that period of that day, which was on a Friday, it got worse and worse and worse until that night. It was like I had needles. It was really bad. Lisa, I'll share it in just a minute. Let me just get through this, and I'll share it, and I'll go back over the really exciting news. Okay. So anyway, ended up calling an ambulance, going to the emergency room, and they were the ones who said, I had severely ruptured 2 discs. So picking up my dad's gun case to evacuate. That's what happened. All right. So as soon as that happened, my right pelvic floor felt like beef jerky. Like, holy hell. It was like contracted and thick and hard. There was nothing soft about it. Now my left side is soft, and my right side is really thickened and so now when I use my wand, I'm doing the same thing. I'm following the length of the muscle, and I'm just trying to get it to relax. And it does. It does. But then, couple days later, it gets tight again, and you got to do it again. We just have to keep working on that while our back is healing. So anyway, for those of you with pelvic floor, get your wand and use it. Oh, I know what I was going to say. Understand too. So what my physical therapist, the first couple of times I was like, how do I use this thing? I don't know what to do when it's inside me. And she kept saying it's a J shape. And I'm like, I don't get it. I don't get the J. Okay, it's a J. I don't understand. Help me. She's like, Jill, it's a J shape. I just didn't get it. And then I got the model. They're absolutely right. It's a J shape. So it's a J shape. Here's the lower part, and it goes up the side. It's a J shape, and it's a J shape on that side. And so as you work with your muscles, you are going to be kind of following a J shape. And for me, most of my tension is right here now. And you end up actually kind of working right by your tailbone. And when you push on these muscles, sometimes you can feel like you're going to need to have a bowel movement. You're not going to have a bowel movement. You're just pushing on the, it's fine. You don't have to worry about it. But that's how you know kind of that you're working in the right area. So we're going right by that tailbone right there, because my ruptured discs are up here, right? But they're all on the right side. Life is crazy. All right. So one last time, what is the news? The news now, Lisa, is that Wake Forest University is now doing human trials of new bladders, where they're taking some of your tissue. They can take some of the tissue in your bladder. They'll grow it out in a lab. They will then put it on a scaffold, which is made of natural, normal it's a structure that's normal, that is not toxic to the human body. It's just like, I don't remember what it is, but I wrote an article on it years ago. So anyway, they grow out your own cells to create basically the equivalent of a new bladder. And Dr. Robert Evans emailed me yesterday morning and told me that they are looking for patients to participate in this new study. So let me just read his letter one last time. He says, "Hi, Jill. I'm writing to see if you would be interested in putting something out over the network. I'm involved in the Wake Forest Institute of Regenerative Medicine, which is the only center in the country that's really creating artificial organs from people's tissue, right? So they are the absolute best in the nation. We have been granted permission from the FDA to proceed ahead with the next phase of our bladder regeneration project and are looking for patients. Specifically, we need somebody with a small bladder capacity of under 150 with severe frequency who would be willing to participate in this bladder regeneration project. They would have to agree to undergo a procedure where we would remove a 1 to 2 inch square piece of bladder. This would then be processed and the cells placed on a scaffolding where it would grow to about 500 mLs or a 500 ml piece of tissue. We would then use this bioengineered augment to enlarge the bladder. The hope is that we would see a drop in the number of voids per day since the bladder would be so much bigger. This would not be for somebody who has pain but does have a small bladder. The ideal candidate would have what we in my lab refer to as a bladder-centric phenotype without systemic manifestations. Initially, I did not think IC patients would qualify for the study, but I have discussed this with everyone involved, and based on the criteria set by the FDA, there is no reason someone with IC cannot be considered for inclusion as long as they meet other criteria. If someone is interested, they would have to be in North Carolina or move here for the study, but if they do, we can help them find a place to live. If anyone on the IC network is interested, they can call or email him. And so I'm not going to give out his phone number, but if you think this would apply to you, and you are interested in learning more about this absolutely groundbreaking research study, I need you to email me, icnetwork@mac.com, icnetwork@M as in Mary, A as in Apple, C as in Charlie.com, and I will forward you his email with his contact information. So he's asking, he wants to talk to you. I'm just not going to give it out where thousands of patients might email him. That's not helpful to him, and that would be abusive for him. But if this is something you think might apply to you or you want to learn more about this, please send me an email. Send me an email, and I will forward you his this email, and you can call him tomorrow. I've got Judy's email. And the announcement of a red flag alert tonight. Yes, such is life in California. Katriana says, "Hi, Jill. I live in New Zealand. I just want to say thank you so much for the IC network. It has got me through some very painful nights and has taught me a lot about this condition." Oh, honey, I'm so glad that you're able to join us. And I hope that you know about Dot Milne. Dot Milne runs the IC New Zealand group. I think I last got an email from her maybe a year ago. Fabulous, fabulous lady. And so they do have an informal IC group in New Zealand that you might be able to participate in if you don't know about her. That's dot Milne, Milne. And if you want more information, you can go over to our website, to our support center. We list USA groups, but we also list international groups, and her contact information is on the international group page. Alan, let's see, hold on. Peony says, "My pain gets extraordinarily worse when I use my wand, but my pelvic physical therapy never told me how to use it. She said just to buy it and watch the video." Yeah, you definitely need to talk to her about that pain because you're not supposed to push up into your bladder. So imagine a clock. So the top of your bladder is 12. The bottom is down by your rectum. That's 6. And then you've got You've got 9 o'clock and 3 o'clock. You never work around 12. You're always working between 3 and 9 o'clock. Okay. So if you're pushing up in the wrong place, that could be the problem. But you need to absolutely tell her that, because you might also be doing it wrong. Maybe you're pushing a little too hard. Maybe you're not using the right lube or enough lube, something, but clearly something's wrong. Yeah. And the book it's stunningly helpful. Lisa says, I think all men with IC should have a pelvic floor exam. Absolutely. I'm going to say the great majority of men that I work with, and this is my personal experience working with men for 28 years. The great majority of men that I work with who've been diagnosed with IC and or prostatitis, when you go back in their history and you talk to them, you find pelvic trauma. There is a history of pelvic trauma and or pelvic floor dysfunction. Almost every single, in fact, it's rare that I can't find pelvic trauma in talking with them, and or once we start going over the pelvic floor symptoms, it's really quite interesting. Alan says, you mentioned internal for PFD. How does that work for men? The same way, except it's rectal. I'm sorry to say it is rectal. It's the only way you can reach those. But Alan, there's a book. I mean, listen, this book is the bomb. In my opinion, this is the best book. There's another book called Ending Male Pelvic Pain by Isa Herrera that is just written for men. So you might want to consider getting both. But this is written for men and women. All the images compare male versus female. And as an example, Dr. Weiss it took him 15 years to write this book. This is the epitome of a love letter for patients, because he knew he was retiring. And he wanted to make sure he gave you a roadmap. And it's just a stunningly good book. So as an example, this is cyclist syndrome. I mean, the images in this book are just groundbreaking. They're so good. And so here we can see where that bicycle seat pushes up in, and the pink area are the perineal and rectal branches of the nerve, right? And so you can see why so many bike riders end up with pudendal nerve entrapment, is because that bicycle seat pushes right directly onto that nerve, because there are no bones. You're not sitting on bones. The bicycle seat's pushing right up against this, right? Catriona says, I know, Dot, we're going to present at a urology conference in February. Awesome. What conference, hon? What conference? And is anything interesting happening in New Zealand or Australia? Are you guys doing anything new? But what conference is it? I don't know what conference is coming up in February. Let's see here. And you guys, I am simulcasting. So I've got on one computer Facebook, and this computer that I'm staring at right now is on YouTube. I just have a camera mounted on this computer, but it's actually over on this computer where you would be looking at the side of my face. Abby says, they'll take my bladder out if I join the study. You know what they'll do is they'll take a 1 to 2 inch piece of your bladder, use that to grow a whole bunch of new tissue based upon using your own tissue. And then they'll do something called a bladder augmentation. So they're going to attach that new piece onto your bladder and dramatically increase your bladder capacity. It's called an augmentation. All right, guys. Well, listen. So we need lots and 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 lots of prayers. We are going into a very severe fire thing tonight. It's identical in weather to last year when we almost burned, and I canceled surgery I was supposed to have tomorrow because I'm the only person that can drive my parents, which sucks. It was a little optional oral surgery to get an implant. Um, uh, so I won't be sleeping tonight, and I won't be sleeping tomorrow night because you cannot sleep during these. Somebody has to be awake, because if a fire starts, you might only have 30 to 45 minutes to leave. 4 years ago, we lost 5,000 homes. That anniversary, I think, was yesterday. So we have a lot of PTSD. So I would really appreciate as many good wishes as possible, because I've been doing my stop sign, deep breath, minimize the thought. I've been doing that. I woke up doing that this morning. It's like, no, I don't want to do this again. Don't want to do this again. All these fires, it's just so scary. It'd be easy if I was by myself, guys. I mean, it would be a lot easier if I were by myself, right? I mean, because I can get out. I can get out. But when you care for a 92-year-old who couldn't outrun a mouse because she's got a bad hip, and a 99-year-old who refuses to leave until he sees actual flames, the stress level is ridiculous. And so I am earning my angel wings. Thank you for listening to me vent. Francine said, would you tell me a little bit more about calcium glycerophosphate? Is it safe to take with every meal? Does it count toward my calcium needs? Yes, it would count towards your calcium needs. Calcium glycerophosphate basically is a mineral that acts to buffer the acid. Think about Tums, kind of the same thing. The brand name is Preleaf. Preleaf is actually a sponsor of the IC network. You can see it up on my shelf right there, right? Love that company. So Preleaf was invented by Dr. Alan Kligerman, back with a company. He owned a company called AK Pharma. He was a master scientist. He also created Beano and Lactaid. And he ended up creating Preleaf like 35 years ago. Preleaf is the most well-known supplement in the IC world by far. It has been used by tens of thousands of patients very successfully. If you have to go to grandma's house for whatever and eat her lasagna without offending her, taking a 2 Preleaf before that meal could be remarkably helpful in reducing the acid from the tomato sauce. And so it's considered literally the safest supplement out there. I'm not even I think in 28 years, maybe I've talked to 2 people that had a reaction to it. The challenge is it is calcium, and that calcium is going to go somewhere. And so you don't eat it like candy. I don't recommend eating it all day, every day, just randomly. You only eat it before you're going to eat or drink something risky. Now, can you do that daily? Yeah. I mean, it's should be okay. But if you're prone to kidney stones, they want you to reduce your calcium intake, you might not want to take it. You might do better instead with a little tiny bit of baking soda in a glass of water, like a quarter teaspoon of baking soda in a glass of water. But for the most part, calcium glycerophosphate, actually, I just sent out an email about this. It's now classified as the first medical food recommended for the treatment of IC flares due to diet. And that's very, very exciting. So it now has that classification as a medical food. And guys, it's so if you get my newsletter, I sent out our mini fall food newsletter. I like to send out food newsletters a couple of times a year. The great thing about the fall season is that the foods that we love that are associated with fall, like pumpkin and squash and things like that, should be completely IC friendly. So I have another website called IC Diet Project, the IC Diet Project. And I'm going to type this in here. This is something that Preleaf has sponsored for ever since, we did it jointly years ago, like 10 years ago. icdietproject.com. And here for you guys on Facebook. So if you want to find some cool, fun new recipes of food, bladder-friendly foods that you might enjoy, go check it out. I love that website. I get to work on it once or twice a month because I have a whole family of websites dedicated to IC. We have IC awareness. We've got ketamine cystitis. We've got hunterslegion.org. I've got COVID cystitis that we're just building right now. And a couple of other websites that are all relevant to IC. Abby says, I just need to get rid of the burning in the bladder and the pins and needles feeling around the pubic area. I've been doing okay, honey, that happened to me too. I had pins and needles a couple years ago, like 2 years ago, just random out of the blue. I started getting little pinpricks on my outer labia, like at the hairline. Like, you know how if you ever accidentally pull on a pubic hair and you get that weird, that's kind of what it felt like. It felt like I had my pubic hair stuck in a zipper, right? And I'm like, okay, that's kind of weird. You know, you're sitting there going, okay, that's weird. You get up, you go to the bathroom, you take a look. Okay, nothing there. What the hell? And it kept happening, sometimes on the left side, sometimes on the right side. And over the period of a week, it went all the way from the front, all the way to the back. And then it got into the actual labia, right? And so it was like I was being poked by a needle on the left side. And then 3 minutes later, I'd be poked by a needle on the right side. So I'd go to urgent care, see a gynecologist there. He goes, it's yeast. I see it. We'll treat you with yeast. Didn't work. Go to my regular doctor a month later. She goes, it's eczema. It's just what did she say? Eczema or something like that. She thought it was skin related. So she gave me all the steroid creams. 2 months later, didn't work. Actually got much, much worse. Much worse. So then, like, I wasn't wearing underwear. I was wearing dresses. I couldn't wear pants. I kept having this pins and needles sensation, right? So finally, I asked for a referral to the pelvic pain specialist at Kaiser Permanente here in Northern California, doctor down in San Francisco, Dr. Jennifer Schmidt, and had a phone consult with her. And she reads the case. And like the first thing she says to me, other than hi, Jill, she says, you do know that your muscles are tight and you have a pudendal neuralgia, right? I'm like, what? Because I always associate pudendal nerve entrapment. I've never associated that with pins and needles there. I always associate pudendal neuralgia with more pain, like in my butt cheek or by my rectum, not there. And I was stunned. Anytime you have pins and needles, we know nerves are involved. Absolutely, nerves are involved. And so, she goes, Jill, it's vulvodynia. Come on, your muscles are tight again and they're squeezing a nerve. So she sent me off to physical therapy again. And I go to physical therapy and it's like, yeah, my muscles were rock hard again. And then she also gave me a topical lidocaine estrogen jelly to use to calm the nerves on the skin. And it took about 6 weeks and it's fixed. And now I pay attention to that feeling, hon. Every now and then I'll get a little prick again. And I know what to do. I know to get out my wand and to work on my muscles to get my muscles to relax, right? Because it's the muscles that are squeezing the nerve. Catriona says it's the USNZ conference moved from this month to February due to lockdown. I'm going with Dot to talk about what self-help I do as a patient. I've had a flare since last Christmas and I had 6 Iolaril stills and feel so much better. So that's new for me, New Zealand. Good luck in your fires. We don't have Iolaril here in the United States. Iolaril is a combination of chondroitin and hyaluronate in a bladder installation. And it's not approved for use here in the United States. So you're lucky you have it. We don't have it. So for somebody with a IC subtype 2 bladder wall driven, where we know that it's either estrogen atrophy or the bladder wall needs to be protected, Ilaril is a really awesome bladder installation with really good research behind it. Abby, you got to know the right stretches, hon. You can't just make this up on your own because you don't know what muscle's tight. For all you know, you could actually be stretching exactly the wrong muscle and making it worse. It's really important that you try to go to a physical therapist once first so that they can identify the muscle group, hon. They have to identify the muscle group so that we know what exercises to do. Okay? Yeah, internal work works really well. It really does. It's the only way to get to these muscles. So, all right, guys. Well, listen. So I gotta go. So, what do we always have to do? You got to make sure that you've taken a shower, which I already did this morning. I washed my hair, so I'm good for 5 days or 4 days. I got to go finish my washing because if they turn our power off for 3 or 4 days, we're screwed. So if you don't see me for a couple of days, just know that it's a fire and just pray that we get through it. All right, here's your homework for 15 minutes a day. I need you to do something for your spirit, hon. This is hard. You're lonely. We're all lonely. Okay, you're not alone. Believe me, you're not alone. We are all there with you right now. If you can, try to get outside, go sit in the sun, and just be. Let the birds singing provide you some ease. Step off the electronic device. Just try to be out in nature a little bit if you can, even for 5 minutes. Just do it. Take your dog for a walk if you can. All right, for 15 minutes a day, I need you to do something for your bladder and or your pelvic floor. For God's sake, get out your freaking wand and do your exercises or your stretches, whatever the heck you do, or make an IC-friendly meal. I made chicken, rice, broccoli casserole the other night. Worked for 2 nights. I'll take it. For 15 minutes a day, I need you to do something to improve your knowledge level up here. So, think about, again, seriously, if the book is free, there is no excuses. Breaking Through Chronic Pelvic Pain is free on Kindle Unlimited. I would like to get IC 101 free on Kindle Unlimited too. We just haven't been, it's very complicated. Understand, getting stuff set up as Kindle on Amazon, very complicated, but I'm trying. All right. Or come on over to our website and read our latest blog. I have a writer, Stacy, who writes wonderful blogs. And let's see, what do we have now? Again, on IC Network, you can do these all from our front page. Ideas for a fun and IC-friendly Halloween, 18 relaxation tips to calm your anxiety, article on chronic fatigue, intro to our new free app, Bladder Tracker, as well as new articles on the UTI vaccine, COVID, cystitis, et cetera, et cetera. And then, whoops, oh crap, what did I do? Okay, and then last but not least, seriously, you have to remember that anxiety will intensify your pain. If you have pain and you are anxious, your brain thinks your life is at stake and it sends you into fight or flight, and that is going to intensify your pain. It is very, 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 very important that you work on reducing your anxiety levels. That is why every good pain management program has a section on anxiety. You shouldn't take it the wrong way when somebody says you got to work on your anxiety. You do. It's all about pain processing. Pain accompanied by laughter is minimized by the brain because you're laughing. Pain that's accompanied by anxiety will be intensified by the brain. So if you struggle with anxiety, if you're struggling with negative thoughts, then you've got to work on that. I've got a video on our website, IC and Anxiety. It's in my Living with IC video series. Please watch it. It's so important that you not let that anxiety get out of control. We have a 3-step system. Stop sign, deep breath, minimize the thought. Our goal is not to let the fight or flight get out of control, which is going to send you spiraling. Works like a charm. Anne says, does estradiol cream cause bloating? I don't, not for me. Let's look it up. Can anybody else watching? Anybody else experience bloating with estradiol cream? Let's see. Common side effects, yes. Common side effects of estradiol include nausea, vomiting, bloating. So the answer is yes. Interesting. Very, very interesting. So you're going to need to talk to your doctor. Make sure you let them know about that side effect. Maybe they might consider reducing your dose, maybe to minimize that. I don't know. That's definitely between you and your doctor. I cannot get in between you and your doctor. My job is to get you back to your doctor, kick you in the butt, and get you back to your doctor with new questions. We're going to open some new doors of treatment for you. Alan says, thanks, everyone. I always feel relieved watching your videos, Jill. We try. All right. All right, my friends, be well. You are not alone. And remember, no shame, no blame. You've done nothing wrong. This is not your fault. You're hurt. Just like everybody, you're hurt. None of this vicious mind game, thinking that you're damaged good, thinking that you're unlovable. It's not true. You're no different than somebody who was hit by a car. You're hurt. We have to get you through this. Okay, injuries happen, healing happens, but I don't want you to hide. I don't want you to hide it from your family. If you've got children, the worst thing you can do is hide this. You've got to role model for your children that it's important to care for family members who are not feeling well. And if you hide it, they'll never learn. And it's important that they learn compassion, and it's important they learn the concept of being there for others who cannot be there for themselves. So no shame, no blame. Ask for help if you need it. And just know I'm here, and I'd love to talk to any one of you guys too. You can find me over on the IC Network website. Our phone number is over at the top of the page. Our phone number is right on the top of our Facebook page too. Mondays are my day off. We're going to be in we're going to be in the middle of a fire. So who the hell knows what's going to happen tomorrow? So you might want to wait until later in the week. Okay. All right, my friends. See you later. All right. YouTube is shut.